Very much. Well, good afternoon, everybody. So lovely to see real faces here. So exciting to be able to share with you this afternoon. And of course, you know, we have all the speakers online. It's really great that they were able to be with us today, especially the ones who had to get up really early. So we'll have more to say on this. But just to start, I begin today by acknowledging the Noongar people, traditional custodians of the land on which we meet today, and pay my respects to their elders past, present, and future. Big welcome to everybody, and of course, big welcome to our Minister for Health, Amber Jade Sanderson. Thank you for taking the time. That shows how important this topic it is for you in health. And Mariah? Yeah, perfect. I think we also have in the audience Dr. Brian Walker, who's MLC, but I don't know if he's here. And the Chief of Staff of Nick Goyron, MLC, Michelle Verkerk. So without further ado, I'd like to introduce the Minister, who basically doesn't need introduction. Everyone knows her so well. I would like to welcome the Honourable Amber Jade Sanderson, MLA, Minister for Health and Mental Health. Minister Sanderson was appointed to the Health and Mental Health portfolio on the 21st of December last year in a very difficult COVID-based environment, and I don't think it's changed. Obviously, many challenges remain, Minister. We wish you luck with everything and well with all your endeavours. Now, when I met Minister Sanderson was all about the end-of-life choices. So thank you for your outstanding support in this field. Also for your support for the Perron Institute and the peak bodies such as motor neuron disease of WA and of course palliative care WA. So we are grateful for your attendance today to welcome the attendees to the symposium. Thank you.
Thank you, Samar, and I want to thank you for having me and inviting me to open the symposium this afternoon. And I'll start by acknowledging the Whadjuk people of the Noongar Nation and pay my respects to their elders past, present and emerging. And to thank you all for your commitment to palliative care and for attending today. And today the symposium asks the question and seeks to reframe how we think about palliative care, particularly in our communities. And community approaches to caring for people at their end of life and families have existed for many generations, probably until more recently when we've seen a more medicalised model of palliative care emerge. And that idea of family and community support has probably broken down a little. And it's important that we regain that and reharness that. You'll all know that people living with a terminal or life-limiting illness only spend around 10% of their time in informal clinical care. The remainder of the time is much more in those informal settings, at home with a spouse, with partner, with children, as is the case of a close family member. It was our whole extended family were there, certainly for periods of months. And that was a really important time for our whole family and part of the process of understanding death, understanding losing someone, but beginning that grieving journey afterwards. And it was a really incredibly important part of it for me personally, to be part of that whole process with the family and with my loved ones, the people that he cared for the most as well. The term compassionate communities was first used by Australian experts in the mid-2000s to describe focus on early intervention and the social approach to many of the issues experienced when people have life-limiting diseases. And since then, the term's been growing and the momentum has been building. It's now an international movement and a core part of the public health approach to palliative care and end-of-life care and bereavement across many, many jurisdictions. And that's clearly evidenced with the number of international attendees today. And it's great to see everyone come together. It really does encourage that shift, that cultural shift around care in it becoming a much more community-based effort. And I do genuinely believe, and one of the many, many lessons that I learned from the end-of-life choices inquiry, and for me personally, it's one of the most meaningful things I've done in my life and without doubt in my professional life. And I had not had a huge amount of exposure certainly to palliative care and end of life before that. But what I learned was that the way someone dies impacts on the way people grieve and the way people process that grief, and whether they're left with lifelong trauma or whether they're able to process that and move on. And there's a sense of comfort and knowledge that that person had a good death. It had never occurred to me before that that was such an important part of life. But it really is central to that. And that's why this is an important approach to palliative care. And I am genuinely and deeply committed to helping to improve that across our community. And the concept recognises that we care for one another during these times of grief. And it's not just about health and social services, that everyone has a role to play. And here in Western Australia, there's a number of great examples which you'll hear of, including in the Southwest. Some large programs, some smaller informal groups and programs. And I think Albany is one of those communities which is very, if there's the right word, literate about death or literate about end-of-life choices in a really positive way, in March this year, the WA Department of Health provided $80,000 of grants across the state to support the development and expansion of these initiatives. And as I said, you'll hear more about those. You'll also learn about other applications of the compassionate community approach by world leaders in the field, and they'll provide examples and outline the evidence, implications and potential for the replication of their programs in other regions. There's no standard model, and examples do vary greatly, which makes it important to exchange notes and compare experiences. As I said, my experience on the end-of-life choices committee was quite profound for me personally, but we did make a number of about 24 recommendations around palliative care. A lot of the focus was on voluntary assisted dying, but actually a significant number of those recommendations focused on the spectrum of choices available to people at end of life, and palliative care is absolutely central to that. We've implemented the vast majority of those recommendations. I think there's around 3 left that are on track, including improving access in regional communities, improving access in the northern suburbs, and improving access through the Silver Chain home care program, not just hospice-based care. So, you know, we recognise as a government that this is an important part of our health provision and our provision of community support, and we're very committed to that. And in closing, I want to thank Professor Samar, Aoun, and the Perron Institute's chair in palliative care for her work in organising this conference and commitment in this area, which has been very clear since the minute I first met you. And I also want to acknowledge all of you and today's participants for taking the time out of your busy schedules and for your commitment to this area and this important discussion. It is encouraging to see this global movement grow, and that conversations about death and how we die are becoming less taboo, less culturally hard, and that people will have and are having access to genuine choices at end of life, and that we can give people and their families, those left behind, the best possible outcomes through what are some of the most challenging circumstances they'll ever face. So thank you, and I wish you the best and good luck in your discussions, and I hope you take a lot away. Thanks.
Thank you, Minister Sanderson. That's really wonderful words. We're so lucky to have you, such deep understanding of the topic. So we have 285 people connected today, 70% of them from Australia, and the rest from the UK, Belgium, New Zealand, USA, Canada, Ireland, Bahrain, Hong Kong, Rwanda, Slovakia, Sri Lanka, Trinidad, and Tobago. So welcome everybody. I think they're probably up there. See me. And it's a mixture of community members, researchers, clinicians, other service providers, not-for-profit organizations, and students from all over the world. So that's really fantastic. So without further ado, I'd like to introduce Professor Alan Kelleher. Now, the video we're going to play for Professor Kelleher was taken at the launch of the Southwest Compassionate Communities Network in obviously the Southwest. And that was in 2018. And I always play it at the start of something like this because he really sets the scene so well into the importance of compassionate communities. And he's such an entertaining speaker anyway. And he's the one who founded, you know, what we call the new public health movement in palliative care, or health promoting palliative care, or public health approach to palliative care, or now it's called the compassionate communities movement. So he has a big imprint on the field, and I'm really delighted to share with you this. Can I just say there is a panel discussion at the end. So if people would like to text their questions on the mobile number there, or they want to use the chat box.
Samar and Holly have asked me to speak about the importance of compassionate communities, and you're starting a compassionate community in your area in Western Australia there. And so I'll talk a little bit about why this is important. There are really basically 3 major reasons why you need to do this. And the first one is what I call the 95% rule. Less than 5% of the time that a dying person spends, or a grieving person spends, is spent in front of a doctor or a nurse. 95% of the time a dying person spends, they spend alone, or with family, or with friends, or their animal companion, or with their TV, or with the internet. That's where the bulk of time is spent by dying people. And it doesn't matter if they're inside a hospital or in their own homes. 95% of the time they spend with that group of people I've just mentioned. If you look at the international studies, it's about 8% of the time patients spend in front of a nurse, and about 4% of the time they spend in front of a doctor. So to turn that on its head, 95% of the time, they'll spend that time either alone or with people like you and me. That's a fact. If you care about end-of-life care, you've got to ask yourself, what are we doing in that 95%? And the answer from professional services is not very much. Not very much at all. And the only way we're going to make an impact on that is two ways. Either we put a hospice and palliative care service on every street corner, or we get the community involved to take up their responsibilities in that 95%. And I don't think we're going to get a hospice or a palliative care service on every street corner. You may remember back in the 70s and 80s, the neighbourhood watch movement. You remember the neighbourhood watch movement? The neighbourhood watch movement was created because people were worried about spreading crime. And there were calls for more police officers. There were actually people who wanted a police station on every street corner. And the cops knew that was never going to happen. That was never going to happen. It was better if communities took some responsibility for safety and for crime prevention. And that meant culture change. That meant getting people who were used to minding their own business, not looking out at their neighbour's house or their gardens or their windows, just minding your own business, getting that set of cultural values turned around so as that neighbours were actually encouraged to look into their neighbours' gardens on a regular basis. They even see through their neighbours' windows to make sure that the people wandering around in there were actually their neighbours. And if the people who were trying to crawl into their neighbour's back window weren't their neighbours, maybe it was a good idea if somebody called the cops, and that was called neighbourhood watch. We're trying to do the same thing in end-of-life care. The frail elderly, the people dying of life-limiting illnesses, the people grieving, the people with long-term care responsibilities. They're not on their own. They're part of us. We have a responsibility to do our bit for them. And that's what the 95% rule is about. And that's one important reason why we have compassionate communities growing up all over the world. The second reason is it's not the dying which is the problem. We all die. And it's not the grieving that's the problem, because we will all grieve. The problem is what public health people call comorbidities. It's what comes along with dying that's the problem. It's what accompanies grieving that's the problem. It's the anxiety. It's the depression. It's the loneliness. It's the social isolation. It's the stigma. It's the social rejection. It's the lost school days, the lost work days. And it gets worse. It's the suicides, and it's the sudden deaths. These are the problems with dying and grieving and caregiving. And funnily enough, if you compare the studies of people with serious bereavement with people living with life-limiting illnesses, whether that's cancer or whether it's AIDS or motor neuron disease, the comorbidities are very similar. And all of those things are amenable to prevention, or if we can't prevent them, harm reduction, And in any case, we can act early rather than late. Early intervention. Our watchwords in compassionate communities all over the world is what we can do, what can we do around prevention and harm reduction of these things which commonly accompany dying and grieving and long-term caregiving. What can we do about the depression? We don't want to send people in for medication or counselling. Most people don't need medication or counselling. They need support. They need support. They need friends, or they need better friends. They need co-workers, or they need better co-workers. They need their fellow students and teachers, or more informed students and teachers. They need us. They need a compassionate community. This is not some vague word about feeling kind. This is a practical set of strategies that come from us. They come from our neighbourhood. They come from our schools. They come from our workplaces and trade unions. They come from our churches and our temples. They're everywhere where we are. And when you're living with a life-limiting illness or grieving, they're everywhere where you are. In healthcare today, in every speciality, they have this public health component. There are community initiatives everywhere. End-of-life care is the newest kid on the block, and it's come late to these insights. But if you go to a cardiologist, no cardiologist believes that seeing him or her as a cardiologist is the last word on heart health. In fact, cardiologists don't think they're about heart health at all. You only see a specialist cardiologist when you have a heart attack or when you have a heart problem. What you're supposed to do is look after yourself. You're supposed to eat right. You're supposed to exercise. You're supposed to take care of yourself, avoid stress. And then, when something goes mildly wrong, you see a GP. And when something goes seriously wrong, then you might need to see a consultant, a specialist. And that's when you beat a path to the cardiologist's door. Nobody in trauma medicine thinks that they're about accident and emergency. Nobody in casualty thinks that. You go to casualty when things go wrong. When you ride a bicycle, you should be riding a bicycle with a helmet. And you know why? When you go to the supermarket, you look around at the breakfast cereal. You don't choose the breakfast cereal with 100% sugar. You know not to do that. You pick the healthy one. You pick the one with 80% sugar. You're supposed to wear your bicycle helmet. You know you're supposed to wear your seatbelt. You know you're supposed to wear a condom. Some of you like to wear all three at once. Each to their own. The question you've got to ask yourself is, what are the end-of-life care equivalents? They are in our neighbourhoods. They are in our schools. It is insufficient. It's a 1950s fantasy to think that end-of-life care is just about the local hospice or the local end-of-life care palliative care service or the bereavement counsellor. The bereavement counsellor is not our first line of support. Our friends are our first line of support. Our family, our dog. We need to learn to use that more systematically. We need to be systematically involved. We need policies to help shape these things. We need to be engaged. We need to become not just healthy communities. We need to become compassionate communities. Samar and Holly have asked me to speak about the importance of compassionate communities, and you're starting a compassionate community in your area in Western Australia there. And so I'll talk a little bit about why this is important. There are really basically three major reasons why you need to do this. And the first one is what I call the 95% rule.
Okay. Did you remember this? The 95% rule. I mean, you can't forget that now. I didn't know it runs again. Okay, well, that's setting the scene in a very pragmatic way. And the next speaker, it's my pleasure to introduce Dr. John Rosenberg, who is the current president of Public Health Palliative Care International, and he's based in Queensland. And John is another entertaining guest speaker, but I don't know, he may be more formal today. And he's talking about from global to local. Welcome to Compassionate Communities in Palliative Care. Hello, John, good to have you.
Thank you, Samar. I'll just share the screen as I should. So I just want to confirm that you can see the screen. Can you see the, somebody give me a wave or?
Just if you could turn on your full screen out of the presenter mode.
Oh, you're seeing the split, aren't you? Hang on, just bear with me. Is that better?
Thank you.
Okay, thank you very much. So you should be seeing two photographs. One is of the curtain tree fig at Yungaburra on the Atherton Tablelands way up north, and north of here, I mean. And then the other is of Nudgee Beach, and that's about 10 minutes from my home. And when I am asked to provide these kinds of remarks at the beginning of an event like this, I guess what I want to bring home is that okie doke, I'm the president of Public Health Palliative Care International, and it's in that capacity that I'm speaking with you. I'm also a senior lecturer in the School of Nursing, Midwifery and Paramedicine at the University of the Sunshine Coast, which sounds as much like paradise as it actually is, the Sunshine Coast. But I'm also just a bloke. I am a son, a brother, a husband, a dad, a granddad, a friend, a neighbour, and I'm formerly a caregiver of some family members as well. So this is really reflective of what we bring to compassionate communities. We bring our sense of ourselves from an idea down to something practical, from a global to a local focus. And so I just wanted to make some remarks at the beginning of this, this event to reflect that. It's the key to compassionate communities that we all bring our knowledge, our skills and our experiences from rich and diverse perspectives, and that's its strength rather than a threat to its integrity. Alan Kelleher said a phrase there, which is people like you and me. And so whether we have a formal role in compassionate communities or we come from a less formal role, each brings its own important perspective to that endeavour. So we talk about the global movement, and we are also talking, of course, about ourselves. Just briefly wanted to take this opportunity to tell you who Public Health Palliative Care International is. So we're an international association, and we are really advocating the ideas that Alan has put forward in that video, that we are promoting the both in practice, in professional, and then in local application, the communication between not only our members, but anyone, our members and our allies and our friends and those who support this idea that public health approach to the practice of palliative care is something that will achieve some of the goals that, that Alan talked to. So we have an association with a membership, which you're welcome to look at. There is our website. But that's the paid advertising part over and done with. It's the implementation of early intervention and harm reduction and the reduction of comorbidities and all of the things that come along from those issues that we really want to focus on. So we're really sitting then with compassionate communities being a part of this public health palliative care approach. And we talk a lot in public health palliative care about death, dying and loss and care being everyone's responsibility. And one of the things I always ask when that is asserted is, well, who's everyone? And of course, we go back then to the opening remarks I made, which is that it's you and me. It's people like you and me. We have formal and informal roles. We have different connections with different people at different times. And that's really what we bring to the experiences of death, dying, loss and care that our fellow citizens are experiencing. Fundamental to the public health approach, though, is that the community is an equal partner. Now, as a kind of a lapsed community palliative care nurse, I am sometimes on committees and that seek to have community representation on them. And sometimes it's people like me who have been healthcare professionals as clinicians, and now I'm an academic. But I think that when we talk about equal partnership, we have to think beyond the contribution that those of us with professional experience can offer. And indeed, I know that we have advocates and people with life-limiting illnesses and their carers in this audience. I was going to say tonight, but it's today for some of you, of course. So it really seeks to redress that imbalance between the influence that a healthcare service may have over the caring and the experience of living with a life-limiting illness and indeed grieving. Equal partnerships is something far beyond a simple consultation with members of the community via a committee or a survey. It's actually engaging mutually between services and communities and the civic life of a community in decisions about planning for, provision of, and responsibility for end-of-life care in all of the ways that we talk about that. The other point I would make here is that it's intentional. It's, and Alan mentioned this, it's not something random. It's not something that we do because we feel nice and we're good people. It's actually an intentional creation of these equal partnerships. And it goes across policy, research and practice, as well as the life of a community. So it's something for those of us who are in healthcare to really embrace. So this active and respectful collaboration is really at the basis of the provision of public health palliative care, in which compassionate communities is a component. The question of cultural change is an important one because I just actually right in front of me here, I've got a poster and it says, "The citadel of established practice will seldom fall to the polite knock of a good idea." And I think that that's actually important for those of us who have good ideas, like public health palliative care, like compassionate communities, to really take a sobering moment to think about that. Just because we think it's a good idea doesn't mean that people are going to embrace it. And I think that it's occasions like today and the work that's being done before today and beyond today that really enable us to understand how it is that we can change culture as citizens, not just as experts or as people with experience, but as citizens in partnership with one another. So I want to just briefly share with you something that Julian Abel, who's in the audience, I see. Hello, Julian. He may well speak to this later, so I won't labour the point. This approach to understanding public health palliative care and the way that specialist palliative care especially can be understood really maps out that it isn't all about, as Alan said in his presentation, the kind of what the specialists do. We have specialists and we have a generalist healthcare, but then we have compassionate communities and we have the civic life of a community. And each of these works in an interconnected way in order to bring about compassionate communities and public health palliative care. Now, I'm just looking at the chat in case somebody is saying, John, you're nearly out of time. No, that's Julian saying hello. So hello right back. So compassionate communities sits within a kind of a perspective of providing palliative and end-of-life care. And now I'm trying to make my slide go forward. So let's talk a bit about compassionate communities. And my mind actually goes back to 3 years ago when some of the people who are in this event today, we were in the Blue Mountains, and within probably, I think it was about 3 months of that conference event, we had our terrible bushfires, and then of course we had COVID. And here in Australia, we have a far too familiar understanding of natural disasters. And of course, we are seeing this all over the world. One of the things I like to say is that Aussies know how to rally around. It's something we do. And I'm sure that this is true of many communities in many places around the world. We know how to rally around. We know how to pitch in and help people when disaster strikes. Imagine if that was also our disposition when we were dealing with the dying, the deaths, and the grieving of our fellow citizens. And grieving is a good example, and Samar, I believe you're going to be talking a bit more about this when we talk about whose business is it. And we begin to look at that 95% rule and understand that compassionate communities is a whole of community approach, because it has to be. It can't be just simply something that the professionals do. But the greatest strengths come from the community and the professionals coming together to provide that kind of support. Putting the public into public health, and I'm talking a lot here about partnerships because it really is critical to success in public health, palliative care, and in compassionate communities, because partnerships are more than a transaction. Partnerships are actually a mutual agreement for shared goals and shared responsibility for achieving those goals. And so unless we are able to address the imbalance in power between organisations and health services and so forth and the wider community, then we're always going to fall short of the potential that sits there when we, particularly when we embrace the capacity of the community. And the Minister made reference to the literacy of the Albany community. And Minister, I think perhaps the term that would have nailed it was death literacy. There are a number of variations of that phrase, of that expression, but death literacy is really a way of understanding the capability, the capacity of a community to provide support of people, both who are dying and their carers and those who grieve them. Yeah, that capacity within the community. So just briefly, because I know I'm running out of time, I was part of developing the Death Literacy Index, and when we were testing and validating that tool, one of the things we discovered was that, you know, like I'm the nurse in the family, so when my father was dying, I was the one who was called upon to provide that care. And we found that healthcare professionals had higher death literacy, generally speaking, or, you know, not markedly different to the general public, unless they had had personal experience of being a caregiver in a palliative care setting, palliative care scenario. So non-professional, doing that as a caregiver. And so it is experience that often assists people most to become death literate. There's some information about death literacy that you can obtain. A Google search will help you find it. And there are different elements of death literacy that I won't go into here. However, it kind of breaks into a map our understanding of how we can be literate in how we create and maintain compassionate communities. So being local, it's this coming together of community members being encouraged to be knowledgeable and informed about death, dying, loss and care, and adapting practices and behaviour, which is that cultural change in some measure. But it's also about healthcare services, palliative care services, bereavement services, providing expert care, providing high quality care, but embracing these two elements in a way, in a genuine partnership that enables a community to become a compassionate one. Aussies know how to rally round, so do many communities, and I think COVID has shown us that. It's about that rallying around being quite intentional, quite deliberate, and embracing the civic life as well as the community life, as well as the health professional life. So these are just a few reflections that I offer you at the beginning of your of this event, and I wish you all well. I hope that it is an enjoyable occasion for us all. Thanks very much.
For staying on. Okay, it's me now, right? Yeah. Okay, so I haven't really introduced Ty. I'm a very able technical assistant. Without her, I couldn't do any of that stuff. And of course, Robin there, she's again very able in that space. And thanks to all the Perron Institute staff who have helped. Got Tennille here, we've got students there, Frankie and Pia and Denise, of course. So thank you for your help. Okay, so how do we put all that together in a practical way, right? And this is where, so I won't dwell too much now on, so which arrow do I do? I've started already. This one, going this way. Yeah, I've tried, see, oh good, it's not much. Okay. So compassionate communities is an idea, a practice, an aspiration. It's inclusive, it's committed to systemic change, and this is the focus for the work that we have been doing in the Southwest. And as you have heard, it's a key element of a public health palliative care approach. So, okay, I won't dwell on this again. The key issue here is that the community is an equal partner in everything we do to provide really good quality healthcare at the end of life. So it requires a shift in the culture of care and support, care that's more sustainable and affordable, and it high levels of community control and ownership, in a nutshell. So the famous 95% rule, this is like in a picture for you. So 5% of somebody's day is spent with formal care, and the 95% is spent with spouse, caregiver, family, friends. That's why there are a lot of resources in the community, and all these people can be part of providing good quality at the end of life. Now in Australia, the number of Australians dying will double in the next 25 years. And according to the latest Productivity Commission report, many Australians are dying in a way and in a place that does not reflect their values or their choices. And their end-of-life journey is punctuated with avoidable or unwanted admissions to hospital, with the confusion, loss of dignity, and loss of control that comes with it. And it doesn't need to be like this. If we think that way, and this is the way it is, death is a social event with a medical component. It's not a medical event with a social component. That's again, Professor Alan Callagher. And of course, Libby will talk about you know, the medicalization of death, you know, in the Lancet report, which she was the first author. So again, how are we doing in Australia? Just to set the scene, dying is increasingly becoming institutionalized, with 25% increase in hospital palliative care admission. Just in the last few days, the Australian Institute of Health and Welfare spending on key health services is 14 times higher for Australian in the last year of life than for other Australians. So 24,000 versus 1,700 per person. Hospital is 3 times more costly than community palliative care. Now, 70 to 80% of us want to die at home, but only 14 to 20% are able to do that. 75% of Australians haven't had end-of-life discussions. Less than 10% of us die with an advanced care directive. And really, WA Health and Palliative Care WA are doing a great job in this space. So I think that 10% is going to increase. Watch that space. Nearly 50% of over 60 years old are at risk of social isolation. 1/3 will experience some degree of loneliness later in life. So social connectedness impact cannot be overlooked. It is a health determinant. People who are more socially connected are happier, physically healthier, and live longer. Those who are socially isolated are less happy. Their health declines early in midlife, their brain functions decline sooner, and they live shorter lives than the ones who are not socially isolated. So, and again, Dr. Julian Abel will show this in greater length. This is a longitudinal study, and it shows how the impact of social relationship on reduction of mortality, and it's even better than any of the lifestyle choices that we make, whether it's exercise, whether it's diet, you know, and so on. So I'll let him speak more about it. Now, in Australia, when we did the national survey for bereavement support, we have about 1,000 people from all over Australia take part. When we asked them, who's helping you? If you can see, like at the start, like family, friends, and funeral providers came right at the top. About 80 to 90% relied on those in their community. Now, right down at the bottom, the professionals, they've been used very little because the community is doing a lot of the work, which is great. So this is what we should expect. And this is the first empirical evidence that we have for compassionate communities at the bereavement stage. And it really explains the public health model of bereavement support that we developed back in 2015, where mostly people are in low risk of developing complicated grief, and they can be supported by their family and friends. Only 30%, well, it's not only, but it is quite a bit, they need additional support. But again, this is how do you build the capacity of the community to help them in terms of volunteer-led groups and peer support. And 10% would need to go probably to mental health professionals. And that's really changed the way things are done all over the world at the moment, because before that, because everything was so, again, medicalized and pathologized, if you had a bereavement, everybody tells you, oh, you need to go and see a counselor. That's not the case, right? Now, this evidence has proved, you know, and I think people now are much better at resource allocation in terms of who needs bereavement support and who doesn't from the professionals. Now, when we ask them, was it helpful or unhelpful having, you know, these sources of support helping you? Now, again, as you can see, the ones who were most helpful, the blue, and least helpful were family, friends, and funeral providers. So again, the community is thinking they're really getting good support from their community. Now you look at the professionals, the red is much more. Psychiatrists didn't fare very well, I'm afraid. You know, but we're not generalizing, right? But this is what the community have said. So again, this really gives us, you know, this wonderful evidence that we are doing a good job as compassionate communities. So the benefits of a compassionate community, again, people and their carers are supported better. Equity of services, this is so important, and I'll get onto that a bit later. Community members have a sense of purpose in supporting their community members. They really want to help, but they don't know how. We need to give them that permission to be able to help. People learn how to care for one another at the end of life and can share it with others. And this is what we say to people in need. It is okay to ask for help, because if you don't ask for help, you are de-skilling your community. They're all ready to help you, and you really need to say yes, or maybe in another week or so, but don't say no, because you just shut all the social networks around you. And then you are in this isolated, space where your health is going to deteriorate. Financial savings can be realized through reductions in hospital admissions and emergency presentations. And Dr. Julian Abel can talk about this. He did fantastic work with primary care, where he showed that there was a reduction in hospital admissions for the area of room where there was compassionate communities work with primary care compared to the wider Shire. So having had all this evidence, we started the Southwest Compassionate Communities Network in the Southwest. And our motto is every person, every family, every community knows what to do when someone is caring, dying, or grieving. We were one of the groundbreakers communities. Albany at that stage have started before us with Commonwealth funding. We started from community members coming together and wanting to do this work. These are some of the lovely compassionate community connectors. And I think 5 of them are on online, which is greetings to all of you. And we, again, talking about formal and informal networks working together, we really need to do that. Now, you realize we're all spaced out. This is because COVID, we couldn't huddle together for a hug, yeah. So got different photos for the time we live in. So what do we want to get out of this? To develop, implement, and evaluate a model of community volunteers to support people living with advanced limiting illness or palliative care needs. To develop and evaluate a training program to assess the feasibility, acceptability, and preliminary effectiveness of this community model of care. Now, we've done all that. At the moment, we still have the effectiveness, which is going to be led by Professor Angus Cook from UWA. Thank you, Angus, for doing this work. But it's now, I got to say, thank you to our colleagues in Belgium, Steven van der Stikelen and Luc Delian, who wrote this chapter in now the famous Public Health Palliative Care book there, just published, the co-editors Julian Abel and Alan Kelleher. And there are complexities and challenges in researching public health palliative care, because we are talking about implementation in real-world settings, which are complex systems in which to undertake research. And so it presents a challenge to traditional research methodology. But this is how we did it. We had a mixed method research design. The first one was about longitudinal design, following those families and connectors in their work with cross-sectional measurement, pre and post intervention, and a qualitative design using semi-structured interviews with families, connectors, and referring health professionals, with the aim of giving as much information if other communities want to start something similar. We did publish the protocol for the work. And so these are the 3 target groups. We have the patients and their family carers, we've got the connectors, and we've got the caring helpers. The connectors are the ones who seek the caring helpers from the community. So the role of the connector is to enhance those networks within those circles of care, which again, Dr. Abel will talk about. This is taken from his article. Connectors provide assistance to the person affected with advanced illness and their family by identifying additional social and practical support they may require from within their local community, and also tap into formal and informal networks. So this is the first thing they ask a family: who is your network? And let's see how they will respond to asking them for help. The role of the caring helpers, their members could be members of the family, friends, neighbors, or other people in the community who are willing and able to assist with activities such as walking the dog, doing the shopping, collecting prescription, going to the library, mowing the lawn, making a snack, tidying up, sitting with a person who needs a break. Now, this seems such small tasks, but you will see how much effect it had on families. It's almost, as the connector said, it's little effort they put in for a big reward. And this is what people want. So these are the domains within which the connectors and the caring helpers work: personal care, medical, home, transport, social, food, pet animal, and preparation for end of life. So families would tell the connectors, yes, the neighbor could help me, but I don't want to ask. Could you ask on my behalf? And this is what the connectors did. So those are the people we looked after in this particular research program. The ones that are in the red are the ones who their level of unmet need, or their dependency on the system are either medium or high, and also their networks are either low or medium. So they needed help in both ways. So we had 20 connectors doing the training since July 2020. 13 connectors could stay with us for the long term. Up to long term, I'm saying 18 months, really not that long. Median age of connectors was 62.5 years, ranging from 28 to 74. The follow-up of families, each family were, well, in the median was 18 weeks, but some were 3 weeks, some were a whole year, 52 weeks, depending on their needs. Average number of families per connector, 3, but we had some connectors who could take 9 families. So it's very much what they can do, the way they do it in the community. It's nothing really set in concrete. We really needed to make it as organic as possible. This is the results of the training program. As you can see, the blue one is the post-training, confidence that they've gained. And it's increased quite a lot and significantly from the green lines, basically in before the training program. I love this, statement from Sallnow and Kumar. Community volunteers are trained to diagnose suffering, not diseases. Doesn't matter what disease somebody has, it's how they feel, how they live with that suffering. So 85 families were referred from palliative care and chronic disease teams. 43 families participated. The rest were either too close to death, or they were too involved with chemo. They were traveling to Perth a lot, or they didn't want anybody come to their home, basically. So it's fine. There were a lot of reasons for that. 47% were home alone. This is what has actually stunned me. We didn't realize we're going to have so many who, it's not like they don't have families, but where are they, So the median age of patients is 74 years, from 34 to 90. 44% were male, and 47% had cancer, 33% cardiac respiratory disease, and 14% neurological. So the type and frequency of support, like from all this wheel that you have seen, look at that, nearly 80% social support. That's what they needed. They want somebody to come sit with them, have a chat, have a cup of tea. The rest, was very, of course, we provided that, but again, that's something really interesting. Connectors have helped or sourced help, for instance, professionals to home visits to do the wills, advanced health directives. My aged care applications, they looked at how to help people, increase services, liaising with the service providers, applications for disability parking, equipment access, mail delivery, or organizing meal trains, house cleaning, transport, medical appointments, to medical appointments or social occasions, joining community groups, all-time dancing, crafts, walking groups, men's shed, gardening, firewood, social visits. But the important thing is that last one. You can do this, is giving that empowerment and ownership for people to get out of their homes and be integrated back in their community. And this is what the connectors did in a really, really successful way. Now, who are the caring helpers? And this is another, it's full of surprises, this project, actually, for me, type of caring helpers who supported the patients. So, I guess because we had about 50% home alone, not a lot could rely on families or neighbors, but community service groups and individual community members were the majority who came to the help of these families. And that means that when we look at those circles of care again, the naturally occurring networks who were able to help, only 26%. While there were facilitated networks where the connectors looked out to who else is in the community who could help if we can't tap into the internal networks. So again, we go to these circles of cares, the inner, the outer. This is where most of the people who came to help. For instance, we reached out to Rotary clubs, right? So they did, volunteer to come and help somebody be a passenger in their seat to drive them around Bunbury when they just moved in and they lacked confidence and they had illnesses. So just sitting with them in the car, showing them where Coles is, where the library is, just help them a lot. And this person, they didn't know each other. So just like, how do you reach out, basically? So the first primary outcome was about social connectedness, and we used the modified medical outcome study social support survey, quite a long name. And this is what we asked the families before we started the intervention and after the intervention. So in terms of practical and tangible support, do you have someone to help you if you are confined to bed? Someone to take you to the doctor if you need it? Someone to prepare your meals if you are unable to do it yourself? Someone to help you with daily chores if you're sick? Now, in terms of social and emotional, someone to have a good time with, someone to turn to for suggestions about how to deal with a personal problem, someone who understands your problem, someone to love and make you feel wanted. So as you can see, we have increased the social connectedness. It's a significant difference with the p-value for those who are interested in this. And the 2 subscales had increased as well. So this is our major outcome that really wanted. So once we have established this, we don't really need to say anymore, because we know, as you have seen from the start, once you have social connectedness, all the health outcomes are going to improve anyway. The second way of measuring this is assessing the practical and social needs and support networks. So again, we looked at those families, and if they had a scale of 2, if they were able to complete a task independently, the second lower one requires some help, and the last one requires another person to complete all their help. In terms of availability of social support, members of the person network provide regular help, ad hoc help, or no help at all. So again, as you can see, although the dependency stayed the same, obviously these people are very sick and they're going downhill, so they still needed the help, but the availability of networks of support had increased by 2-fold, again, looking at the social connectedness there. Then we've asked them to rate from 1 to 4 the impact that this program had. And as you can see, the highest impact for them was in reducing social isolation. The orange one is what the client said, and the blue one is what the connectors said. They rated their work. Now, they're very modest connectors. They've always rated theirs less than the families, because I don't think they knew how much of a difference they made until they heard that from the families. So we tried to do some network mapping for just one family. As you can see here, this is one family, and that's the kind of help they had before the intervention. And then after the intervention, with the connector reaching out to community members, family, even formal services, you can see the busyness of the interactions that's happened there, and more people coming on board from the community. So 74 interviews were undertaken, which is a large number of interviews, but we really needed to do this because, again, to basically explore all aspects. We had 28 interviews with families, 27 interviews with the connectors, covering 37 of their patients, and 19 interviews with 8 health professionals. So what the patients and carers said always keeps her promises. A lot of paid carers really don't care, just filling in the hours. She goes above and beyond and seems to care. She knew when we were a bit overwhelmed, knew when to get involved and when to step back. It's necessary for people who don't have strong existing networks, for people who are isolated. It will open up their world. I can ask her anything, no matter what I talk to her about. She always has a sensible answer. Pretty amazing. This is one of the caring helpers for this lady with COPD. And this is the gardening group that was helping people with their gardens. So for instance, this the middle person basically was talking about blackness that would flood over him and loom for days like a heavy rain cloud. And that blackness has gone because they came and helped, and the garden was his passion, and he couldn't do anything before that. So what did the healthcare team say? Really positive, especially for clients who are early in their journey and for those who are isolated and don't have good family support. They will be encouraging more people to make use of their informal networks and support. She's very socially isolated, and our professional service is not enough to meet her social needs. So I'm very happy for her that she has a consistent person to talk to. Added another string to our bow, especially in small rural areas where there is a lack of formal services, easy to implement. The connectors, great to be given someone specifically to help fill their needs and tick their boxes. So rewarding to watch their quality of life improve. Being able to connect to those in need has brought very obvious benefit to the volunteers and the receivers. The more you give, the better the reward. The reward is greater than the effort. Fabulous program. So I get asked all the time, so what's the difference between this model of volunteering and the traditional model of volunteering? So we managed to basically get an article done. Is somebody not on mute from those online? Anyway, and the difference that we have found, and this is speaking to the connectors, they can exercise more autonomy and have more agency in providing care. This model is about a sustainable social capital emerging from genuine social encounters. And this is fresh ways of engaging with the community, because quite a few of them had worked in volunteering before. So one of them said, it's not a walk in the park though, like other voluntary positions I've had, a whole different level of commitment, but I would do it again, highly recommend it. It's a lovely way to do volunteer work. If you really enjoy being with people and talking to people, you end up, I don't know, being part of their lives. It's really fulfilling in that respect. So it's not a job, you come back, you report to a health service, I've seen this person, can I do this for them, the way you do it in the community, it happens. They're not reporting to anybody. So, well, we became finalists at the Palliative Care in WA Awards for our compassion community approach to palliative care, which was nice. And I don't know why it's not moving. Do you do something there so that it moves? Click, it's better. Okay, right. So translation in progress. Basically, where do we go from here now? So the first thing that's happened is that WACs have taken on the program as business as usual. So it's a program, it's continuing. And what they said to me lately, it does align so well with the place-based approach to care that they are doing. This is a new kind of lingo for me, so it's great. I keep learning all the time. Great, so that's good. Local government engagement. We're starting with a Compassionate Boundaries Charter, whereby the whole community need to know how to support each other, basically. And of course, Albany and Dr. Kirsten Orett will be talking about how things have happened in Albany, and we are learning from that. Engagement with primary care. GPs in Busselton very interested to be part of this, and we engage with them in a compassionate connector program. So that's basically being discussed. And we had aspirants joined the last training program that we did. So they've started a community, compassion community, they're connectors. And I believe Albany are also starting a connectors program. So we're open to actually take this out, the educational program, the concept, everything to everyone who needs to. And I know Palliative Care WA are very interested in that. So we had a lot of pressure points in palliative care still when we did the statewide review from consumer perspectives. And I'm just trying to tell you how the compassion community approach fits with all that. Family care support. People said they haven't had enough family care support from palliative care services. Grief and bereavement support, well, this we know we've always been lacking in this, and that's something we really need to do more work in. I don't know why it's going all over the place, but anyway, I had them all sequenced. Health and death literacy of consumers, again, as we talked about, death literacy, it's something that we are doing through compassionate communities. Workforce education and training, again, I think, WA Health have got a fantastic program and they're doing all that, based from the results on that, of this review. And then if we don't have integrated models of care that integrates all that, it's probably, not going to work very well. Non-cancer conditions, they're really missing a lot on this. And this is where basically the last article written, we call them winners and losers in palliative care delivery. Certainly non-cancer conditions are in the losers category, and we need to do something about it. And this is a beautiful thing about compassion communities approach. It fits in nicely as an enabler. So again, we have all the circles of care where all the community things are happening. We've got those services here that need to be integrated, and to some levels they're not all integrated, and these are the enablers. Compassion communities have been working with the families on integrating those services for them, and again, with the not-for-profit organizations, so they are everywhere. Right, so to finish it all off, I have a video at the end to show you how it's working with families, but I thought I'll go through all that before, because once I go to the video, I can't come back unless I have help. So, So give a family a fish, it's a charitable act. Teach a family to fish, it's called sustainability. Organize a community-based intergenerational fishing collective, that is social change. And this is what we're doing in compassionate communities, the last one. So thank you for all the organizations that have taken part in this particular research program. WA Health Translation Network has provided the funding for the research program. The staff from WACS, thank you very much for all your referrals. I mean, they're still doing it, obviously. GP Down South also took part on this. WA Primary Health Alliance were, big partners. Project coordinators and assistants, PRE skiers, Kerry Gunton and, Robin Richmond here. Connectors, you've done a marvelous job. Without you, this program wouldn't have been successful. We just learned from you so much. And of course, the families who have agreed to give it a go, but I think they did once they've met the connectors. They thought such great people to basically connect with and, have them as friends of the family. So just a short video to show you exactly how it's worked on the ground with the connectors. Yep.
In 80 at the Blacktown Workers Club, mid-year, and 5 days later we moved in together. So we've been together nearly 41 years. We married in 88, and by that time we had 6 children. So we're a blended family. Gus had 2 children, I had 2 children, we had 2 children. Gus was very, very fit. He was, he'd gone back to uni as a mature age, around about 60 years old, I think he went back. He loved books, writers, authors, always had. He always thought he had a book in him, they say everyone has, and he did have. And then he became ill, and we never thought it would last.
For the first few days, the doctors were saying he's got a very big growth on his lung, and he would not be surviving probably days. It wasn't going to be long. And so, because he didn't want to die, he wasn't ready, we asked really that we go somewhere that we can, help to. The doctors were worried that we were trying to prolong Malk's life because we didn't want him to leave, but that wasn't the case at all. We didn't want him to leave until he was ready to leave, until he was ready to die. So, in there, I looked at the compassionate program and asked to join and be part of it.
To have Gus suddenly, very, very suddenly unwell, it just threw us in a tailspin. I think everyone knows they could get sick at some point, but you never think it's going to be you. And we never thought it'd be permanent.
We still have kids sitting in desks. I came into contact with this connection, this program. There was something left after a meeting in hospital, and I looked at it and wondered about it, and had put our names down, talked about it with Malk.
I had the privilege of coming in and meeting with Mary and Malcolm. I could see they both had needs. Both were so loving towards each other and were so worried about the other person they weren't discussing their individual needs. My role was to come in and I guess get that conversation going. Both incredibly capable people, and I saw myself as being an advocate, just to slow them down and say, what do you need? Yes, you're capable of doing that, you can do that, you're intelligent people and you're in control of this situation.
It was wonderful meeting Jenny, and we got on straight away. And she's the type of person that you can talk safely with, if that makes sense. That you can sit down and you can have a conversation and talk about things that you can't talk about to other people, about how this has impacted on your life, and be honest. You don't always get the opportunity with family or friends to be honest.
I do a lot of listening with Jenny, and with Gus I was able to get a retired principal to go in and spend time with him. Gus is a very academic man and he likes an intellectual conversation, so it's sort of finding people that kind of meet that need. Yeah.
On end-of-life care, upskilling the community is a really key point that we are working towards in the Compassionate Communities Network. There's nothing worse when, you know, somebody dies and then the family is lost. What do they want? We've never had that conversation. And I think this is where the community needs to focus on, and I think we will get a much better advanced care planning than, say, a clinician doing this in a, you know, in a hospital or a clinic, because we're talking about a life.
No one wants to feel helpless, and it took me a little while to realise that this wasn't so much about helping, it was about supporting and being beside people during times when they otherwise couldn't cope on their own, and that was me. I was just overwhelmed.
I would have completely, I believe, fallen over if I hadn't had the Compassionate program and being involved with Jenny and the Compassionate program.
Nobody wants to die, but if people are allowed to speak about their fears around death, I think it makes that process more bearable for them and those that love them.
Well,
Samar and Holly have asked me to speak about.
oh well, that was a bit cheerful after the connected video. Oh dear. That's it. Yes, we move on now to Dr. Julian Abel, who you have heard a lot of us mention his work already. But I'm sure he has a lot of new things that he wants to talk about. And you know, one thing, Julian, that sort of struck me in our conversations, you said that compassionate communities is one of the most effective therapeutic tools we have in improving length of life and well-being. I think that's such a strong statement. So welcome, Julian. Julian is the director of Compassionate Communities UK. And really what they're trying to do there is the broader rollout of compassion communities in both primary care and end-of-life care. And then again, there are multiple projects that are happening between the UK and other international programs. So without further ado, palliative care, major blind spots and the new essentials. Welcome, Julian.
Thank you. Can you hear me all right? Yeah, good, jolly good. So look, what a pleasure it is to be here, and how do I follow a presentation like that? You know that Samar is amazing, because the work she did on bereavement really changed the way that I think the overall model of bereavement. And then this presentation in particular about showing the benefits of taking a compassionate community approach is groundbreaking and highly significant. I'm going to talk more about that, and let's see what we can come up with in the time that we got. So I'm really happy to be here and great to have such an international audience. So the palliative care blind spots. Oh, hang on, I've got to make sure I've just pressed the right button before I start the sharing, because otherwise I've got some videos to play. Yep, we're safe. That's jolly good. Right, there are 4 major palliative care blind spots. I don't even know if blind spots are the right word, because somehow these things are even bigger than palliative care itself. But let's just go through them and see what we come up with. So palliative care, there's a few things that are problematic with the kind of whole basis of which palliative care works. One is that it's deficit focused. That when you look at how palliative care in general looks at helping and supporting people, it's done through needs assessment and control of symptoms. But if we think about what really makes our life worth living, once you put the needs assessment and the symptoms to one side, what is it that matters most to us? Then it's around the people we know and love in the places we know and love. Social ecology. And when you look for the literature about what living well means at end of life, and I find this so amazing, that the literature on living well for both the person with the illness and with the people who surround and support them, it's not just scarce, the literature is absent. In other words, we in palliative care have made the assumption that living well is control of symptoms and needs assessments, which is crazy, because living well outside of palliative care is all about relationships. When you look at the research on it, humans are social animals. We evolved as social beings. Survival of the fittest is some kind of nightmare scenario invented by Herbert Spencer, not by Charles Darwin. Actually, Charles Darwin's last book was The Expression of Emotions in Man and Animals. He was intensely interested in relationships. And there are some outstanding pieces of work in the world of medicine. They just kind of point towards this stuff, really. And Samar has already shown you this slide, but this slide is a meta-analysis of over 348,000 people, looking at the impact of reducing your risk of dying from a variety of different interventions. And this is an extremely carefully conducted study, and mortality was the length of time that was seen for around length of life was 7.5 years. It's a very short period of time in terms of mortality, but even in that short time frame, what you can see is social relationships are more effective at keeping us alive, at reducing our risk of dying, than giving up smoking, drinking, diet, exercise, and anything else you care to mention. And I highlighted down the bottom the drug treatment of high blood pressure because the impact of social relationships outweighs the impact of treatment for high blood pressure by a factor of 4. And I also I have really big doubts about ascribing the increase in reducing your risk of dying with the drug treatment of hypertension being solely due to medication. And actually, why is this so important? Why is it that social relationships have such a profound impact on us? And actually, it's because it's part of our evolutionary heritage. That survival of the kindest is a much better description, particularly for human evolution, than survival of the fittest. We are social beings. If we became isolated when we were living hunter-gatherer lifestyles, our life was at risk. It was a matter of an emergency. And if you think about food security, our ability to bring up children, our ability to, if we're injured, to be helped and supported, it's all about how we cooperate with our community. And when you look for the evidence of this in our biology, it is everywhere. In fact, it's everywhere throughout the animal kingdom. What we're looking at is 600 million years of evolution and 2 million years of human evolution. And you find the evidence in our genomics, in our biochemistry, physiology, behavior, absolutely everywhere. And I really strongly recommend looking at the work of George Slavich and Steve Cole, who have tracked this down to a biochemical and genomic level. It is groundbreaking stuff. But the reality is that compassion is part of our evolutionary heritage, and everyone has the potential for compassion. Everyone. It's there if we choose to use it. And when we do use it, the impact is absolutely dramatic. This is Robert Waldinger. Samar has already given us some quotes, but Robert Waldinger is a 4th study lead of the Harvard and GLUEC studies of adult development. It's been going on since 1938. They've been interviewing initially men since then on an annual basis. And Robert Waldinger is a 4th study lead because it's been going on so long, they had to renew them. Let's hear what he has to say.
Time. So what have we learned? What are the lessons that come from the tens of thousands of pages of information that we've generated on these lives? Well, the lessons aren't about wealth or fame or working harder and harder. The clearest message that we get from this 75-year study is this: good relationships keep us happier and healthier, period. We've learned 3 big lessons about relationships. The first is that social connections are really good for us and that loneliness kills. It turns out that people who are more socially connected to family, to friends, to community are happier, they're physically healthier, and they live longer than people who are less well connected. And the experience of loneliness turns out to be toxic. People who are more isolated than they want to be from others find that they are less happy, their health declines earlier in midlife, their brain functioning declines sooner, and they live shorter lives than people who are not lonely. And the sad fact is that at any given time, more than 1 in 5 Americans will report that they're lonely. And we know that you can be lonely in a crowd and you can be lonely in a marriage. So the second big lesson that we learned is that it's not just the number of friends you have, and it's not whether or not you're in a committed relationship, but it's the quality of your close relationships that matters. It turns out that living in the midst of conflict is really bad for our health. High conflict marriages, for example, without much affection, turn out to be very bad for our health, perhaps worse than getting divorced. And living in the midst of good, warm relationships is protective. Time.
So the next issue is the issue of equity. And when we think about palliative care, you know, the historical development of palliative care, that the bulk of it has been providing care for people with cancer. So when you ask palliative care services about the breakdown of the diagnoses of the people they see, it's mostly cancer, anything from 80 to 95%. but cancer only accounts for 25% of deaths. And what happens to the other 75%? And what happens even in that 25% of those people who don't have any indirect or direct contact with palliative care services? One of the things I've started to do is to ask healthcare providers, who do you leave out at end of life? And it becomes quite shocking. And in particular, Alan mentioned at the beginning, the social morbidities that come around end of life, and of depression, anxiety, school refusal, job losses, suicide, alcoholism, drug abuse, sexual acting out. The social morbidities happen irrespective of diagnosis, and the physical morbidities and mortalities that come from there are really significant. And it is crazy to think about end of life by diagnosis or age. And sometimes you hear this phrase, hard to reach. I hate this phrase, hard to reach. What on earth does that mean? Does that mean that those people who are being referred to are deliberately hiding themselves from services? And that becomes terrible when you think about it in a context of racism, of inequity of access to palliative care for diverse communities. Actually, the so-called hard to reach are the majority of people who die and the people around them. We've heard about the, Samar's already told us about her groundbreaking research about looking at where people get support from. I have an issue with this diagram, as Samar does, and the issue is one around power relationships, because it seems like the pinnacle of support for bereavement is the one-to-one specialist report. But amazingly, you saw in Samar's research that the most effective form of support is around tier 1. And a better way of thinking about it is to think that everyone, 100% of people, need support of family and friends and connectedness, because the social connectedness is the most powerful biological thing we can do. And so that when we're thinking about how bereavement services, at the moment, a small minority of people see the professional support of bereavement services, but actually everyone should connect through family, friends, and neighbors. And this becomes more like a sieve. But it's not just that people work their way down, because even then the professional services need to connect with the 100% of community. And the final blind spot is around research. And when you look at the definitions of what palliative care is from a variety of different sources, it's a very all-encompassing definition. And then you take a look at what are the papers, what's the research evidence in us being able to meet those definitions. And what you see is a really narrow paradigm of what research is looking at. And when you think about the most meaningful things around death, dying, loss, and caregiving is love, laughter, and friendship. And how much do research methods look at that? And not just for the person with the illness, but for the whole of the supportive network. And this narrow view completely is embedded in the whole of research, bound up in grants, in ethics committees, in peer review, in publication bias. We need a new research. One of the things that I love about the research that Samar has done is you can see the evidence for some of these new types of research, which is looking at social connectedness. And this business about social connectedness, showing an intervention which improves social connectedness, gets absolutely to the heart of it, because that's the thing that has the most powerful biological effect. Let's now have a think about how palliative care can be different. And Alan and I edited the Oxford Textbook of Public Health Palliative Care, some fantastic, 44 different authors from around the world, encapsulating this whole approach in one place in the first time. And we just did an introduction to basically explain it. Hello and welcome to the introduction to the Oxford Textbook of Public Health Palliative Care. My name's Dr. Julian Abel. I am one of the editors, along with my colleague and friend, Alan.
Hi, I'm Alan Kelleher, friend and colleague of Julian Abel. I'm the co-editor with Julian on the Oxford Textbook of Public Health Palliative Care. And together, we're going to introduce the book as a whole. And the first thing I should say about public health palliative care is often people think of public health in the way that universities teach and research public health, and that is in terms of the surveillance sciences. People often talk about public health in terms of epidemiology or health services research or the bench sciences, or they think historically about public health, such as sewerage, clean water, infectious disease, sexually transmissible diseases, those kinds of things. But in this particular case, and in our book, and within the field of palliative care, when we speak about public health palliative care, we're talking about the health promotion traditions, the traditions that emphasize the practice models, such as community development or social ecology or health policy or services redesign or public education, health and end-of-life literacy. They're the kinds of things that we emphasize. And conceptually, health promotion is also about a balance between health and well-being and illness and disease. And traditionally, palliative care has tended to emphasize the illness and disease side. And that's why the emphasis has been firmly and wholly largely on symptom management or symptom science. And of course, health promoting palliative care or public health palliative care does have an emphasis on that as well. We're interested in the prevention and harm reduction and early intervention around the experiences of illness and disease and some of the social morbidities such as loneliness or job loss or school refusal, and stigma and social rejection. So we're interested in that too, but we're also interested in health and well-being, which is the more counterintuitive aspect of palliative care. People often forget that there are positive things that are associated with living with a life-limiting illness, or living with caregiving, or living with grief and bereavement. There's not just fear, but there's courage. There's not just loneliness, but there is love and growing intimacy. There is reminiscence and there is meaning making. And there's a whole group of positive things that are associated with the social nature, not just of dying, but of caregiving and grief and loss. And so the promotion of those health and well-being aspects and experiences at the end of life go together to help with the prevention and harm reduction of the social comorbidities associated with those experiences. This book is about the promotion of those things together, the promotion of health and well-being, the development of the practice models that would help us do that, and the practice models that would help us with prevention, harm reduction and early intervention in this new approach, the public health palliative care approach.
And we also wanted to emphasize that death, dying, loss and caregiving is not restricted by disease or age. And likewise, not by gender, by diversity. It is a question of social justice, that we need to find a population-based model that will help everyone. And also that it's not just about the person who has got the illness, it's also about the caring network that of people who are affected by that. And that caring network extends into community, it extends into our places of work, our places of worship, our educational institutions, it extends everywhere. Death, dying, loss and caregiving is not just a professional issue, it's a social issue that involves all of us. We invited, that'll do for that. John's already shown you this slide, the new essentials. And what we're going to do is we're just going to whiz through in the remaining time we got about how these things can work together. And that we have defined this in the context of these 4 cogs of specialist care, which we know about, generalist care, which is primarily about GP surgeries, etc., etc. But the stuff that makes the biggest difference in life is in our neighborhoods, in our communities, and everyone in all of these areas has a civic life, and the civic life is defined in the 13 different domains in the Compassionate City Charter. And death, dying, loss and caregiving is everyone's responsibility. And it's not just about meeting needs and controlling symptoms. It is about those positive qualities that happen in life of love and laughter and friendship and support and courage and intimacy, etc., etc. And that in particular, that when we formulated the 4 cogs diagram, it is about their interconnectedness. It's about all of this working together. And if you like, the way that I think about this is thinking that the chain is community development. Okay, I'm not going to dwell on this slide. And if you think about the things that each of those 4 cogs can do differently, about how can these professional services integrate with community, is actually, you can think about palliative care services being set up to meet the support of the professionals. And we're using this, since the pandemic, we're using these methods of contact every day. And why not have a team that is available 24 hours a day, being able to talk to other professionals to support them? This is easy to do. And then you can think about how can you set your services up so that if you have that kind of contact, you can go out and give advice and do visits if necessary. And what is this craziness of specialist beds being primarily around for people with cancer? This is some kind of artificial categorization that we've made that doesn't relate to the lived experience of death, dying, loss and caregiving. And we can think about what is the stuff that community can do that doesn't have to be done by professionals. In other words, there's a whole shift in the development of where your professional investment goes, and that specialist palliative care can make sure that they're doing the things that actually enable death literacy in the community, and really practical things. And the Compassionate Community Connector program is a great example of how you enable network development, and that's come from professional services, and that's exactly as it should be. And why do we not train every single carer in manual handling? What kind of insanity is that? I hear sometimes people talk about, oh, we might be sued if we train them and it goes wrong. So you have to ask the question, is it better to avoid the risk of suing and allow people to move the people they know and love who are closest to them in a way that puts both the person doing the moving at risk and the person being moved? Or is it better to find ways of educating everyone that will give them a better idea on how to do it? And then the other thing that the specialist palliative care teams can do is participation in the implementation of the Compassionate City Charter, which is a geographical approach to improving death literacy, about making death, dying, loss and caregiving everyone's business. What can generalists do? Well, proactive identification of people in need of support. And it's not, there is no artificial dividing line between people who are dying and people who've got chronic illness. It's a continuum. And that you can have what matters most conversations. Palliative care is obsessed with advanced care planning about where people die. But actually, people want to know, how can they live well? So why not have a what matters most conversation? This goes back to making sure that you focus on the things that are most meaningful in life. And then linkage and coordination with community resource and systemic after death audits. These only take a few minutes. Anyone who died, you should be having a conversation in primary care about, did the things happen that need to happen? And are those people who are left bereaved, are they connected into their community? And development of community resource in supporting people who are bereaved is key. And community development workers need to be seen as part of the clinical team. What matters most, I'm not going to dwell on that too much. Compassionate communities has got two big chunks. One bit is about the building those resilient networks of support, and you've already heard from Samar about how effective that can be, with the evidence base to show how effective that is. It's fantastic work. And then there is the building of neighborhood capacity and making sure that neighborhood capacity is present. And then there is the building of the integration of the trusting relationships with health and social care teams. And again, what you see with this is that the community development worker sits both in the community and also in the professional space. And then there's a Compassionate City Charter, which I'm not going to dwell on, but is a really important part of this whole picture. And why should we use compassionate communities approach? Because it massively increases the range of stuff we can do. And it changes the nature of the clinical consultation to think about helping people, not just the person with the illness, but those surrounding them, how to live well. Network enhancement, I don't think I'm not going to dwell on this, and time's getting short, but I love this quote from Bessel van der Kolk. He wrote a book called The Body Keeps a Score, and it's a kind of exploration of his life story, where he worked in the field of trauma. And this book is so beautifully written, but it's got so much in there that is so helpful. And I love this quote from this book. Social support is not the same as merely being in the presence of others. The critical issue is reciprocity, being truly heard and seen by the people around us, feeling that we are held in someone's mind and heart. And I would add to that about feeling that we hold others in our own mind and heart. For our physiology to calm down, heal, and grow, we need a visceral feeling of safety. No doctor can write a prescription for friendship and love. These are complex and hard-earned capacities. That's such a beautiful quote. There's more stuff about how can people help? There's practical support, but most important is love, laughter, and friendship. And when you see those slides which says everyone appreciated the social support, this isn't just a nice to have. This is a deep and profound connection at a biological level that gives life's meaning. And when you think about the practical support, is that in a way, that practical support, of course, people are grateful for it, but it is the way in which that practical support is given. That sense of giving without sense of return. That sense of people holding you in their hearts and minds. And that's the thing that makes the biggest difference. Compassionate communities, as the definition is so great. Compassionate communities that recognize that all natural cycles of sickness and health, birth and death, love and loss occurred every day within the orbits of institutions and regular activities. A compassionate city is a community that recognizes that care for one another at times of crisis and loss is not simply a task solely for health and social services, but is everyone's responsibility. And one of the beauties of this definition that Alan put together is he doesn't just talk about the deficit-based things. He talks about the meaning and value, and that the place for intervention is in our workplaces. It's in our places of education, our places of worship, in our civic spaces, etc., etc. Okay, so I think that's enough from me. I think I'm more or less on time, and we'll call that a day.
That was really, really great. Thank you very much, Julian. We have a question. Well, I mean, people want to know where you are, in which city. You're not in London anymore. Where are you now?
So I now live in Cornwall. I live in the back end of nowhere. I mean, that's a relative phrase, because I think the back end of nowhere, you know, which is a great place to be. You got much more of that in Australia. But for the UK, I'm in the far southwest in the countryside with just sea around. It's beautiful.
Oh, it's a beautiful place of the UK. Oh, well, that was really very, very well spoken. Thank you very much, Julian. So yeah, without further ado, we move to the next speaker, and Associate Professor Kirsten Orett. She's an Associate Professor of Rural and Remote Medicine at the Rural Clinical School of UWA and Clinical Director of Palliative Care of WA Country Health Service. So Kirsten has been involved with the activities of compassionate communities in Albany. Right, she's in Albany, if anybody wants to know where she is. And yeah, welcome, Kirsten, and thanks for enlightening us in what's happening in Albany. Now, by the way, I have here at the table pamphlets and lovely work that they've done in Albany, if anybody wants to pick something from there. And Julian, sorry, back to you. I do have the book, the Public Health Palliative Care book, exhibited here at the table, but I realized WA Health haven't got their copy yet, or have you received it? You have? Oh, it took an awful long time. So next time we need to send them express post. In case you need more copies, let me know. Anyway, all right, welcome, Kirsten.
Thanks, Samar, and hello to everyone. And please, for everyone who's there in person, feel free to hop up and grab those things that are out the front so that you can be looking at them while I chat. I will start screen sharing, so bear with me a second while I get that all right. And I'm hoping you will shortly be able to see my presentation. Let me know if it comes up. Just all black for me. Ah, there we are. So are people seeing my screen?
Yes, thanks.
No problems. So I really want to start by telling you very briefly who I am. So I'm Kirsten. I'm a palliative care specialist working and living and belonging to the rural community of Albany on the south coast of Western Australia. But I'm actually feel like a bit of a fraud here because I'm presenting on behalf of a beautiful group of people that have done such amazing work, several of whom are in the room at the moment. You can see the kinds of groups that were around as we went through our Compassionate Albany Charter process. And I'm really going to focus my talk on the practical implementation of deciding that your city is going to form a charter, how we did that, what we resulted with in our work. I'm also going to share a case study with you so that you can perhaps see a little bit of how that has played out in our community. I do want to acknowledge the real lead organisations in this work, which were our city and our Primary Health Alliance, our Country Primary Health Alliance. But working down the screen, you'll see that Creative Albany was involved, carers and representatives from residential aged care, our general practice community, our beautiful Albany Community Hospice, our ambulance service, community volunteers and representatives of our DHACs and our Death Cafe movement, palliative care people and others from WA Country Health and those from Carers WA. And I was very lucky to sit on as a representation of the University of Western Australia. So where I am, for those of you that haven't ever been here, our city is working hard on renaming our places. The Menang name for Albany is Kinjaling, and I'd like to really respectfully pay my acknowledgement to the traditional owners of our land, the Menang people. Albany is a really beautiful city of about 36,000 people. We're classified as outer regional, and many of the areas around us are more remote. We're a very primary care centred health service, but we do have a fantastic regional hospital, and we're blessed to have the last community-owned inpatient hospice in Western Australia. We also have an older population. We are all very well connected with our sense of place. We feel like we belong here. We want to grow up our children here. We want to grow old ourselves here, and we plan to die here. So we were blessed as part of the Greater Choice at Home palliative care measure funded by the Commonwealth Government of Australia in 2017 to gain some funding along with 10 other communities to develop a Compassionate Communities Great Southern Model. We had 4 main aims, and the main one I'm going to be talking to you today is the second, which is around developing the Compassionate Albany Charter. Although the case study will show you how increased community knowledge, skills and involvement around the social dimension of dying, death and bereavement increased, and also how our community is starting to network around those facing dying and loss. So why did we feel we needed a charter? Well, I think we understand so much from what we've heard already that the social networks that we have around us are so important to our health and well-being. And that those that have strong social connections are much more likely to have better health outcomes. But even in a rural community like ours that does band together around good times and bad, there are still many within our community that struggle to ask for and accept help and who don't have significant social networks. You'll see 2 quotes up here. One is from our mayor. This is what he was talking about during the process of why we needed to develop a charter. He's been reminded how much our community cares, but that the charter celebrates both the things we do well and how together we can make our place of living and home a more compassionate place. We wanted Albany to be a place where we don't cross the street to avoid someone going through a hard time, but a place where we reach out and show we care, where people will stop and ask a stranger, "Are you okay?" So obviously our city charter is very much based on Alan Callagher's work with city compassionate charters, which generally have 13 statements of values and changes that organisations within those communities can undertake. So we thought what we needed to do to start with was really envisage what does that look like for our community. So the way we did that was we held a significant number of workshops and then focus groups. We had 107 participants in total, and our workshops were a combination of community members, businesses, sporting clubs, government and other service providers, those representing the young and the slightly less young and the old, our faith groups, our community groups, our non-profit organisations. And we also specifically pulled together our elected members of the City Council, and we worked with them on a strategic workshop, and then went to particular focus groups where we asked them more specific questions about how they thought this city charter will look. We tended to use a World Cafe style where we brought people together in small groups with a table host and others that moved on. And we asked them the 3 questions that we were really interested in. What are we already doing in our community? What could we do to build on this? And what do we need to do to create a more compassionate community? I'm trying super hard when I look down to keep an eye on the time as well. So this is our charter. This is where we ended up. I'd like to read it to you. I belong to a community where everyone recognises we all have a part to play in supporting each other during life's toughest experiences, especially during times of hardship, illness, loneliness, death and grief. We are all touched by these challenges at some point in our lives. Let's have conversations about living well and dying well, and supporting each other emotionally and practically along the way. This has been really one of our key deliverables and was a very important part of those original aims that I showed you. For those of you that are lucky enough to be in the room and have grabbed some of our beautiful postcards, the second part of our charter was where we explored 6 key value-based aspirations that were based on the feedback from our community. So these 6 ones were our shared humanity, recognising that compassion comes from the heart and starts with me. Community mindedness. Let's ask, what can I do for my community? Compassionate organisations. Let's grow, recognise and reward. Compassionate places and spaces. Let's use our places and spaces more to connect and belong. Communication and information sharing. Let's listen, let's ask, let's talk, let's share. And lastly, leadership and advocacy. Let's lead by sharing what we've learnt and listening with our hearts. So you'll see as I go through these next slides, I'm just exploring those 6 values and aspiration statements in a little bit more detail. We really wanted to be a community where people show kindness, understanding and compassion to everyone. One of the participants from our Menang Noongar focus group said, listen in an open way. Don't judge quickly our differences and tell us to just get over it. Respect our beliefs and connection to country and be open to a different way of seeing. We're encouraged to live by values of kindness, compassion, acceptance and care, and to reach out to others in our everyday activities. In community mindedness, just like we've heard, it's the little things. It's the help that doesn't cost people a lot of time. It means the world to a carer. So we're really looking here at harnessing the collective energy and goodwill of our community, encouraging people to look out for one another and to provide support. And we do have existing volunteer networks and street and neighbourhood communities, but we look to strengthen that. So people every day are creating opportunities to ask, are you okay? To stop and listen, to offer and accept help, and to be kind. And equally, we are very blessed in our compassionate organisations in this town, but we realised we do need to be more inclusive of outside of our clubs or organisations and think of the wider community, or even more what we can do within our clubs and see what we can do. We want to continue to value and support the existing services that we have that are so special, like Albany Community Hospice and our dementia support place, Hawthorne House, but also to support and build on community initiatives that address social isolation and vulnerability at any age. And as a community, we want to grow compassion in our businesses, schools, workplaces, clubs, community groups and institutions. And we want to recognise and reward those civic leaders who show us what compassionate action looks like. Compassionate places and spaces. For those of you that have been to our beautiful area, you know that we live in one of the most beautiful places in the world, and in fact have just won the most beautiful beach in the world competition, which I have to have a shout out about that. But it's really talking about creating a sense of belonging in the places where we meet, work and play, and that we do need those spaces because they perhaps aren't naturally there for everyone. It's really about thinking about things like compassion cafes, memorial gardens, and community information hubs and events. And again, our library, our town hall, and our town square are all co-located. And our library has been such an important part of this compassionate place and space response. And equally, they've helped us lead the way in communication and information sharing. Let's listen, let's ask, let's talk, and let's share. We want to feel that we can connect face to face as well as through a whole lot of other mediums, in person, in print, in digital. We need to communicate in ways that link our people, our services and our support networks. And our community felt really deeply that we needed a physical space and physical presences, people and places where someone can connect. And our library, again, has played a really important concierge role in some of that communication and information sharing. You've heard that quote that I read out from our mayor, but we have many within our community that provide leadership and advocacy, and they lead by sharing what they've learnt and they listen with their heart. We want to be a community where we're willing to be bold and be the change we want to see. We want to lead through compassion, inclusion, care, and respect. So within our charter, we also spent some time thinking about how might we make that a more compassionate place. And many of the little idea bubbles that you see here on this graphic are things that are happening already. We do have a much higher uptake of advanced care planning than most other communities in Western Australia. And our hospital is outstanding for having documentation of advanced care planning compared to most other hospitals in our state. We have a very strong sense of volunteering. We run death cafes. We have Dying to Know days every year, and we have amazing artistic events. Given that I have 50 seconds left, please let me just show a couple before I share with you this case study. So we ran a Permission to Die public art event where we worked with community groups, artists, and our Vancouver Arts Centre to create a project where we really allowed people to think about what death and dying might mean for them and those they love, and as a real way to increase death literacy. Part of that was working together to build this beautiful coffin that you can see, but as well as that, volunteers worked together to unwind donated jumpers, to create these little Permission to Die coffins that we left around cafes and businesses and other workplaces and clubs, which had a little instruction on how to make a flower. And the flowers were all around the coffin. People were encouraged to lie in the coffin during the display, and they were able to then have their photos put up against walls. People said things like, it brought up raw feelings that I weren't aware of about what I thought I wanted to happen to me when I die. It was also very apt, as I just lost someone very dear to me before the exhibition opened. It helped me to come to terms with my feelings. And it made me realize I'm not alone with my feelings. And another, it made me contemplate my own mortality and reminisce about those loved ones who've passed away. I've relived that loss a little and accept it again too. And another, this is validated. It's okay to make plans about death. And this exhibition that again was held in our civic spaces across 3 towns around Albany, Denmark and Mount Barker was called In Memory of Ordinary Things. And you can see the beautiful pieces that our community donated to the exhibition, along with the very short stories about why that was such an important memory of someone they loved. Videos were made of several of these, and we've got them available as other assets for our community. So moving on now, you'll be shown the video in a second. I looked after Tony and Heather during their care, so I'm the health professional on this video. But the stars are really Heather, Tony, and the community around them, and a real case study about what compassionate community looks like in real life as an example of how we can play our roles in end-of-life care, how we can form a network, and how we can confront some of those stigmas around both offering and receiving help. It's going to be played for you centrally in a minute, but I just wanted to let you know that we continue to work with both the charter and this case study in community workshops. You can see one of our local chemists here, Terry White. They've all come together for a 1.5-hour workshops. We're really talking around what do compassionate communities mean? What is our charter? How does that play out for our business and us as individuals? So the work goes on, and I really hope you enjoy the video. I'm going to stop sharing and allow Taya to play that for us.
You know, done in Albany, and yeah, we hope to be able to do the same.
I'm 75, I've had a marvellous life, way beyond anything I ever would have expected, and I don't think there's anything that I would not do again, and it's a bit sooner than I had planned on, but I'm not having any negative thoughts at all about the whole thing. I'm actually finding it an interesting project to see how it develops, and the good, the bad and the ugly.
We're fortunate in that Tony is just such a positive person. He doesn't see this as, oh, you know, poor me and this, that and the other. He sees it in life. You know, it's just life.
Right at the moment, this treatment has reduced the size of the thing in my brain, which is inoperable, of course, and it seems to be stable, but how long it'll be, could be a day, a week, a year, who knows. The standard answer is when you ask 3 months, and in 3 months I'll see 3 months. Heather's a marvellous carer. In fact, too good. She does everything for me and always has. If you didn't have a carer, I don't know how you'd get on. We saw staying in the Cancer Council accommodation in Perth for long periods of time, you know, 6 and 8 months at a time. And the one we stayed in was the one that was mainly single people, and they had to do everything for themselves, feed themselves, do their washing, do everything. If you didn't have a carer, establishing any of these sort of networks or activating them in whatever form you choose to do it, I think would be quite difficult. We had for many years been riding with the Albany Cycle Club, but of course they're all less than half our age. But then the over 50s club we learnt about. We've been riding with them. Well, they started out just every Wednesday for a long time, and we got to know them. There's quite a lot of couples in it, and it's a very social club.
I started to think about all the people who I'd been talking to in our cycle group, and they'd all been wondering how Tony was going and saying, can we help? What can we do? How can we help? And I thought, we have this network in our cycle group of support, an awesome network. I just thought there must be some way where we can organise it so that it works well for Tony, it works well for Heather, and it works well for us. All I did was put together a timetable of when people would visit Tony and Heather. Heather was really reluctant to ask people to do something, to go out of their way, to come out. It was a fair travel, you know, some people it was an hour's drive, and she was very reluctant to accept that help. And I said, if we have a roster, it's like once a month, you know, we share it around, we all do something.
Pam approached me and said, look Heather, we can get a roster going so that there's always someone there so that you can continue going to the gym. It's important for you to keep healthy and fit.
That's as important for her as it is having visitors for Tony. When we go out there, all of us, we say, let's go outside, let's have a look at the garden. It's a beautiful property and he enjoys getting outside.
The last couple of days I've spent most of it out in the backyard where there's a lovely warm spot there until after lunch, and then I can go out the front there and sit in the sun, watch the bird life, watch the cows over the way. There's hardly any cars up this road. Something that's completely foreign to my life experience, and I'm enjoying the hell out of it. Right at the moment, the chance of me wanting to go to Perth and get another treatment is so low. It's not zero, but it's very close. I'd rather sit in that chair and look down that valley than be stuck up there in hospital, no matter how good it is, because it isn't going to cure it.
As a landlord, you couldn't ask for better tenants, but we don't think of them as tenants. They're our friends. You know, we've had New Year's with them, we've had Christmas with them.
We've been here for 6 years and they've become good friends, and he's very supportive of the current problem, and so our life has settled down here.
They said they'd like to come home, and I said, yeah, sure. If you want to come home. We'll help you in any way we can.
It was difficult for a while until we got this thing some time ago, which means that when she's not here, she knows that I can call her, or if she doesn't answer, Peter will get it. And if neither of them work, it goes to O, who will say, what do you need, where are you?
But it's also to give Heather support as well, to reassure her that she knows that if she needs something, and it doesn't matter, 24/7, if she needs help, she just has to ring.
Young Siding is a support mechanism. There's a few others around that if you had to call on them, they would drop everything and just come.
What we rejoice in is the circumstances of someone who is loved in their community, whose community feels that they have the capacity to step forward, and that that person and their family is able to accept that love and care. I think particularly in a rural environment, the practical solutions that often people are willing to bring to the table, those are the things that get people through.
We're a close group. We've become closer because we're doing something like this. We're used to being a supportive group, but this is a different experience. But we're talking about it now. We're talking about the end stages of our life, and we often have conversations about what we're doing amongst ourselves to prepare for that. So those conversations are quite wonderful to have. Everybody's very keen to keep going, and I think as we continue, our growth and our development as individuals in a group will be quite special.
The more you see that actually this is just part of life and it's going to happen to me too, I actually think the easier it is for you to die yourself when the time comes.
Well, wonderful story about the cycling club as, you know, the caring helpers, similar sort of model, and their friend Pam doing the connector work, you know, when do people go, what do they do? Fantastic story. So thank you very much, Kirsten. It's great all that work being done. Yeah, so I think we'll just move on to, well, we haven't clapped Kirsten. I think these videos at the end leave us with some, I don't know, sadness, or I don't know what it is, but also, you know, nice feelings of things happening in the community. Okay, last but not least, Dr. Libby Sallnow. Now, she lives in London NHS Trust, and she's an academic working at St. Christopher's Hospice, in Brussels, the Free University, University College London, and also the WHO Collaborating Centre in Community Participation in Palliative Care, Kerala, India. Now, I am so grateful, Libby, that you decided to join us today, because we need someone like you as the lead author to unpack for us this huge report. Amazing title, Bringing Death Back to Life. Welcome, Libby.
Thank you. Thank you. Let me just share my screen. Great. Can everyone see that? Great. So it's a huge pleasure to be here today from early morning in London, and thank you very much for the opportunity to present some of the findings. As Samar has said, this huge report, it started off much larger, I can tell you. It's the edited version down to the 25,000 words that we eventually published. But I've got the next kind of 40 minutes to talk you through the different areas, kind of why we pulled certain themes through, some of the key recommendations, and this idea of a realistic utopia that we tried to come to at the end. So as Samar said, I'm a palliative care doctor. I work in the community in London, seeing people at home, and I'm also an academic at St. Christopher's and at University College London, and at Free University in Belgium. And great to see some people from there online today. Hello. So the first bit I want to talk about is looking at what the impetus for a commission on the value of death. And as we know, the Lancet do many different commissions on complex, thorny issues, but they certainly had not tackled anything like death before. So the reasons were that death, dying and grief are core universal human concerns, but actually how people die has changed significantly over recent generations. And we see this more so in high income, but increasingly in low and middle income settings. Some changes have been for the better. So we look at people are dying later in life, life expectancy has increased, many conditions that were previously fatal are now curable. And some around the world have access to pain and symptom relief as they die. But some changes have been for the worse, and dying is now prolonged. We see people increasingly dying in hospital, disconnected from the networks that we've heard so much about from this morning. And there's increasingly the sense, both in the literature and anecdotally, that people, communities, families feel unprepared when they begin to face these essentially universal human concerns. So the Lancet Commission on the Value of Death was formed in 2018. It was made for 30 commissioners across 12 different countries, a range of people beyond healthcare professionals. The Pain and Palliative Care Commission had been published in 2017, and there was a very clear sense that we needed to make this not about palliative care provision, not about healthcare provision at the end of life, but actually about the idea of death and dying in that broader sense. So we had authors, social scientists, researchers, philosophers, religious leaders, economists to bring multiple different perspectives into this. And as I said, it looked beyond the kind of provision of care and the provision of services to look at a much broader, through a much broader lens of how these times are experienced globally. So it was a huge remit. And we had to begin to try and kind of tether some of these different perspectives together. It was very interdisciplinary from the outset. And so we came across the idea of thinking about death and dying in a systems approach, and using this systems thinking and a systems lens to begin to understand the broad, multifactorial, intersecting challenges that influence experiences at these times. We wanted to look at some of the really broad determinants of what's happening when these experiences take place. And so we looked at structural issues such as gender, race, power, discrimination, alongside access to healthcare services, philosophy, consumerism in healthcare, and economic perspectives. The key messages from the report, they're at the front, and I think it's quite helpful to kind of tailor some of the talk around these key messages. So the first one is that dying in the 21st century is a paradox. And as we began to look at the core contention, which is that death has essentially become over-medicalized and over-professionalized, we began to unpick that actually that's not the case everywhere. And for some places, people are not accessing the right healthcare, which would lead to prevention of avoidable mortality. And actually there needs to be more healthcare in certain areas. When we look at palliative care, only 14% of people globally in the WHO, according to the WHO, can access morphine or pain relief as they die, or even looking at broader palliative care services. So it's not the kind of true to say that actually all healthcare needs to step back, and we need to kind of look at social models. We need different models in different places, and so it's a paradox. Some in high income specifically, patients and people are being overtreated in intensive care, building advanced directives to try and reduce the amount of care they have, whereas other places, often in the same country down the road, people are not accessing the right care. And so that's influencing how, where, why, and when people are dying. Death, dying, and grieving today have become unbalanced. This is one of the core contentions, that the balance between healthcare, social, community has shifted, and that has become unbalanced. We make some very explicit links with the climate crisis and looking at the common delusion that we are in control of, not part of nature, leading to a lot of the current issues around essentially immortality and the pursuit of endlessly deferrable death, and that the links with the climate crisis have the same contention, that we are in control of death and not part of death as part of our natural lives. Rebalancing death and dying depends on changes across death systems, death, dying, and grieving systems. And these are the same systems that look at education, financial systems, hospitals, families. These complex systems exist in many parts of our lives, and that's no difference in end of life and death and dying. As with all systems, the disadvantaged and powerless suffer most, and in fact, many systems are designed to recreate and perpetuate the status quo. But we wanted to move to look at a hopeful outcome, and rather than looking at tracing just the challenges of death and dying, which are well rehearsed and well known, we wanted to look more hopefully and more intentionally to how we might change the future of dying. And so I'll come on to this in more detail, use the principles, the idea of a realistic utopia, a new radical vision, but achievable vision of how death and dying could be in the future. And we acknowledge that the challenge of transforming how people die and grieve today has been recognised and responded to many around the world. And in fact, here today, we're hearing from many brilliant examples of just how that's happening around the world. But more action is needed, as I saw in the chat. You know, this needs to be available not just to lucky communities. This needs to be a core availability for all those people facing these challenges. And a reminder that radical changes across death, dying and grieving systems are a collective responsibility. They don't sit with healthcare, they don't only sit with communities, they don't sit with policy, government, they sit with everyone. These are universal human issues that must be responded to by us all. So I'm going to start by just looking at some of the facts and figures that we collated to give a picture of what death and dying is like in the 21st century. So on the surface, global mortality and life expectancy trends in recent decades have improved, and it appears to be a success story. People are living for longer. But when we look deeper and scratch beneath the surface, there's disproportionate progress both across countries and within countries. This is particularly seen for specific population groups such as women. So in the UK, women with the most deprived socioeconomic status bracket, they have seen their life expectancy not only stall, but actually reverse. And we obviously saw this in COVID, and the same can be seen in the US for women with fewer than 12 years education. Their life expectancy trends are no longer increasing, and in some cases reversing. And when we look at the idea of healthy life expectancy, not just life expectancy seen as years gained, healthy life expectancy is the years lived in self-reported good health, we see that actually it's not kept pace. So whilst people are living for longer, those years are not lived in good health. We see a shift of disease from communicable to non-communicable diseases. This has been well established in the majority of high-income countries for many years, the epidemiological transition, but is being undertaken very rapidly in countries such as Bangladesh, where we see huge reversals and changes from cause of death and main illnesses from infectious, communicable or accidental to chronic non-communicable conditions such as heart failure, CVA, etc. And that sudden shift basically asks a health service and a health response to respond to something completely different in a very short space of time. And these are very underfunded services. So this huge shift raises an entirely new set of questions. And we wanted to build on the Lancet Commission into palliative care and pain relief, which categorizes and captures this idea of serious health-related suffering. And that this health-related suffering is not only experienced in the final months or even last year of someone's life, but can in fact extend and be experienced in many years prior to death. This is a table from the report looking at countries that that commissioners were from. So as we were talking in Zoom groups, we were looking at what the differences on our own countries were. And here we can see looking at overall life expectancy between a colleague, a GP in Malawi and the UK, where I was coming from, nearly 2 decades of difference. So although there are broad trends of improvement, there are still stark differences across countries. And this table begins to look at some of the differences around maternal mortality, deaths from suicide, deaths from non-communicable disease, deaths from communicable disease, and serious health-related suffering. And just showing that actually the picture is hugely different in different countries. And actually the context of how, where, why people are dying must be taken into account to understand how we even begin to challenge and address some of these issues. And so we wanted to really focus on the social and structural determinants of death, dying, and bereavement. And these terms, social and structural determinants, is often associated with health and well-being. And there's been a huge amount of work, mainly by the WHO and other colleagues, who have written to say, you know, health is not determined by the services that we use and the medications that we take. And this has now become really well established, and the multifactorial sense of how we improve health and well-being is well established. But those same determinants are used and determine how people experience these times. You know, the idea that actually education, discrimination, access to services, access to food, those same issues that have determined health and well-being, of course, continue to go and determine the experiences when someone's dying. And the differentials in distribution of power, resources, unequal environmental, socioeconomic conditions, discriminatory policies, and lack of an intersectional lens, all of those things continue throughout life, throughout health and well-being, and into death and dying. It's this kind of idea of a life course approach that we must take. So we came, when we were trying to kind of bring some united messages, some key messages that we wanted to bring from the Commission, we came to the central paradox, as I've mentioned. And so here, this is a picture on the left from my intensive care unit in University College Hospital in London during COVID, where we see kind of the ultimate medicalised death. People are not with their friends and family, they're masked and gowned clinicians, there's no human connection, there's no sense of this person as their own person, it's around their biochemistry, their physiology, and the machines in the treatment. And we don't know how much this person would have wanted, but there's a sense that actually treatment continues unless it is stopped, unless there is a reason to halt it. Whilst we look at other countries around the world, and this map here is from the Lancet Commission into Pain and Palliative Care Access, and it's a map showing the amount of morphine that is available per person who needs it per year. So this isn't amount of morphine available to the country in general, it's how much that person who needs palliative care, how many milligrams per annum they can access. Looking at Canada and Australia and USA, they're bloated, they've got 60,000 milligrams per annum per person. And the UK and Australia kind of, you know, almost normal size, but stretched in some way. And the entire continents are reduced to a thin line of India, Russia, Africa, South America. And so this demonstrates the kind of stark inequity that exists globally, even in something as a very poor proxy for end-of-life care, but the availability of morphine for people with end-of-life care needs. And the answers to this are obviously not straightforward. This is not something that we could solve with the provision of a new service or the provision of a new community intervention. These are complex, nuanced, established and entrenched situations that stem from the complex systems that control them. So the iceberg model is quite a good way of kind of beginning to understand the structural challenges that really determine why these experiences are as they are in different contexts. Looking first, you take the top, kind of the highly visible part of the iceberg is the events. You know, what is happening? It might be that people are dying more frequently in hospital than they are at home at the moment. And that might be the trigger to say, okay, well, let's look to understand a bit more about how this happened. You then go deeper at one level to look at the patterns or the trends. So, you know, what have been the changes over time? What's happening with this event? And you begin to see what is happening increasingly in high-income countries quite recently over generations. And there are trends within cities in low and middle-income countries that the same is happening. We see that increased spending is taking place in the last months of life, and that this is a relatively recent trend again. You then go to look at a deeper layer, to look underneath at the underlying structures, forces that are kind of determining these patterns and influencing these patterns. And here we see things like increased life expectancy and people now dying of chronic rather than acute illnesses. The fact that many previously fatal conditions are now curable, so people are living longer. And this is really shifting expectations of what people think about death and dying, and also their familiarity with seeing someone who is dying, of caring for someone, hands-on caring when they're dying. Increasingly, this just isn't happening. This is happening out in institutions whereby families are not involved in that direct care. So that's again shifting the kind of narratives and the kind of mental models as we go down to the deeper one, which is the kind of paradigms, the kind of sense of what is happening in terms of how people really view death and dying, what value of death means, what a good death means. And here we see increased hospital treatment, giving this sense that there's always one more treatment, that there's always one more thing that will defer death that's available. This kind of belief in modern medicine has almost been equated to kind of a modern religion. sense of what value of life is, and the sense that actually giving someone more hospital treatment, one more treatment often, is equated for many people in valuing that person, valuing that loved one. And ideas of what a good death are. Is it at home being surrounded by your family, or is it kind of fighting to the last in intensive care? And this all links to that kind of deeper idea of our immortality, and why it links back to ideas of mastery of nature and climate change, that we can somehow one day will defeat death, beat death, and that we're in charge and in control of this part of our lives. So this kind of looking deeper and deeper and asking questions at each level, why is this happening? Why is this happening? Gives a frame for how we can begin to understand the events that we see today, which are essentially the tip of the iceberg. So taking a systems approach is acknowledging and addressing the interconnected nature of different events, of how people have lived their lives, the work they have, their employment, school, religious community, cycling groups. You know, this is all part of a complex and interconnected lived reality of someone's life. And this kind of non-linearity is really crucial. You know, introducing something from here to here and expecting A to always equal B is just not going to happen in the complex real world. So, you know, this for someone's life may lead to one outcome. If we did the same thing for someone else, it will lead to something else. When you really look at a real world impact of something, you cannot presume it will always be the same. So non-linearity is a really key component. It's the relationships that exist between components that are central. And there's emergent and predictable behaviours and systems. They have a life of their own. They're constantly evolving and changing, but often they do maintain a status quo, which can be good or bad, depending on your position within that system. And then leverage points exist for significant change, where you can make quite a small shift to the system and actually have quite significant change. Now, we're not the first people to come up with the idea of death systems or death, dying and grieving systems. And Robert Kastenbaum, a US academic, was first used this term to describe the interpersonal, socio-physical and symbolic networks through which an individual's relationship to mortality is mediated by society. And that's how he framed and defined the term death systems. And he describes this framework that there are means for death and dying to be understood, regulated and managed. They often define the meaning of death in the culture or community for which this is taking place. They determine where people die, how they mourn, the norms and the socially sanctioned ways that these experiences are publicly experienced. They encompass different components, places, symbols, and they have functions. So there's parts which is, you know, climate change and public health, things to warn and predict death, protect against early death or avoidable death, also care for the dying, making sense of death. And they exhibit dynamic complexities. They are constantly changing, constantly evolving, and constantly moving. And so the rationale for really using this is that we, at the moment, looking at a lot of our health services research and a lot of the kind of more positivist ideas of new studies to evaluate a new service, often they're using linear thinking, kind of really reductionist reasoning and just static options, not taking account of this much broader dynamic context. And these fragmented approaches can lead to real inefficiencies, unintended or negative consequences, and real inequities. So there's a real driver for bringing together this kind of multifactorial way of change, but also the kind of intersectional aspect of people's lives, that people don't experience things in separation, they experience things as a whole. So this is one picture a diagram that we included in the commission. It was included to illustrate its complexity and the almost impossibility of trying to comprehend the entire whole. So it was not meant to be a map for us all to start working from. And it's one point in time, as all of these maps and kind of diagrams, they just demonstrate an example of how this would be in one context. And this is for dying at home and looking at the huge multitude of different components that feature here. And so if we're looking at rebalancing death, dying and grieving systems, shifting these systems, then you obviously need an integrated approach looking at societal, healthcare, legal, amongst many of the different aspects. And that it's essential to understand, if not intervening in all of them, to understand the integration of all of these different approaches. So once we had kind of looked at the different challenges and we had outlined many of the current issues facing death, dying and grieving today, we wanted to then describe, well, as we said, these systems are constantly in flux and are constantly changing and responding to other broader societal changes. So we wanted to bring the idea of scenario planning in to give people a sense of what may happen if we do not intervene. If we do not take any action or change things, systems will evolve themselves regardless. And so we use the technique of scenario planning. So it's not formal systems modeling, it's imagination, looking at the different drivers that are happening currently and extrapolating them through. And so we came up with 5 different imagined futures for what death and dying systems might be like in the next kind of 30 plus years. We wrote the commission through COVID, but wrote these prior to COVID. And some of these scenarios actually came true during the pandemic. So for example, death overwhelming health systems, whereby the need for healthcare or the number of people dying was too much for healthcare services in northern Italy and in India, amongst other places around the world, for them to manage. And we look at some of the other ideas of immortality, the approach to immortality gaining ground and people actually being able to access extension of their life for huge cost, huge amounts of money, and what this would do for global inequity in terms of life expectancy and access to resources. We looked at the role of climate change and whether this might prompt a reckoning, a kind of greater equity and fairness in use of resources and understanding the climate footprint of escalating end-of-life care, inappropriate treatments. Otherwise, we looked at where things may be rebalanced, a more hopeful scenario, and looking at the role of assisted dying in countries where it currently is not practiced, but understanding there's changes across many jurisdictions changing that, and that introduction would shift and be an important change within death systems to understand. But again, we are not passive in this work. We are all part of these systems and have the ability potentially to change them. And so we wanted to think more intentionally about one of these, which of these scenarios or many other ones would we want to actually take place, and how could we begin to work towards that? So we came up with the idea, borrowed the idea of a realistic utopia from the philosopher John Rawls, the US philosopher, who describes this, a realistic utopia, as joining reasonableness with justice and with the conditions that enable citizens to realise their fundamental interests. And what he essentially described was thinking radically about what would be a society that you would want to live in, that we would want to be part of, that we could imagine would be the best kind of realisation of all our interests within that. But whilst it being radical and hopeful, it also is practical. So it's something that can be achievable within the confines of our system. So it's a radically different future vision of future society, and it looks at profound rather than incremental change. This is not kind of tinkering around at the edges. This is really looking for profound change across death, dying and grieving systems. And it's based on shared vision and principle, and that's the kind of the first premise, to understand what these first principles are and then begin to enact them in a variety of different contexts. So I'm going to talk to now the 5 principles for our realistic utopia that we came up with and that we designed. And these are high level, so these are necessarily high level to allow them to have relevance for all contexts globally. And so the idea is that we present these high level aspirational principles, and each context then looks at what that would mean for them and how they would then begin to put that into practice. And there are examples, before we go into that, of this happening around the world. And we capture them, and I'll come back to some of those. So whilst this is something that is quite utopian, I don't mean that in the kind of derogatory term of that. Actually, this is already happening. This morning, this afternoon, you've already heard of many of these different examples happening in places triggered by people around the world. So the question is, how can we make this something that is universally accessible, that is universally understood as essential? And that's what the 5 principles start going some way towards. So the first principle comes back really to the social and structural determinants of health, kind of understanding the life course approach, and that death, dying and grieving are a standard unmovable part of all our human condition, and that this has somehow been forgotten and lost in much of the debates on how we improve our environments, our health and our well-being. So how people live, the lives, conditions of their life and their health during that time, those determinants have impact into how, where, why, when people will die, the experiences of that dying, and how those around them experience that. Then how people die obviously has a huge impact on how people grieve, how those people who are left behind, how they experience their life going forwards, the role of their grief plays in their life, and how that dying took place influences that. And then knowing how people are grieving, the experiences, the resources they can draw on or not, their understanding of the loss of that person, etc. That has a huge impact on their future life, on their return to work, their mental, physical health, their ability to maintain, form, connect, have relationships in their community. That feeds into their living, and that in turn affects their quality of life, who they are, their health and well-being, which then will go into effect their subsequent death and their subsequent any other supports that they may be having around people dying. So this kind of interconnected nature is something that we very much take for granted and we understand in the fields here, but actually looking at the social determinants of health literature, this is not something that's included. If you read The Social Determinants of Health by Michael Marmot, it goes through early years, education, employment, retirement, and just ends. There's no sense that there are any further life stages past dying, past retirement, and there's an urgent understanding to see death dying as part of the life course and not just palliative care's responsibility, not just certain community group responsibility. This is something that needs to be taken seriously by everyone across the life course. So our first principle is that we must first understand these social and structural determinants and then begin to tackle them in whichever context they are being manifest where we are. The next one, again, speaking to a highly converted audience, I would think here, but dying is understood to be a relational and spiritual process rather than simply a physiological event. And that, again, obviously is something in palliative care or in the kind of allied work that we've heard about today is something that is deeply and fully appreciated, but something that is entirely almost forgotten, I think, in hospitals at times. There are times when people can die well in hospital, but certainly a lot of my experiences have been of disconnected, isolated, prolonged dying that is only looked at through the markers of biochemical physiology and the kind of personhood, meaning, purpose, relationship, spiritual ideas are quite hard to bring into hospitals. Not impossible, but quite hard. And even at home, there can be times when actually these are not brought in. And so the focus has to be on the relational aspects of dying and bringing in the other parts around the physiology as interesting, important, relevant at different times, but not the fundamental driving understanding of what dying is. The third principle looks at networks of care. And this is a real fundamental principle for this. And we often see good examples of networks being developed around certain people who have got the resources, the skills, the connections, and the support to do that. And we see many other people who are deeply isolated and have none of these resources, none of these connections. So what the priority is to begin understanding how these networks can be formed around every single person who is dying, every single person who is grieving. And these networks need to be truly kind of integrated across health and social care. And obviously there are some crucial parts of having, you know, the right team around you, but then the right community resources in terms of people supporting cooking meals, taking dogs for walks, community pharmacy, post office, postman, etc. And then that inner family of understanding how they're supported, who are the main carers, how are people being supported. And often what we see, and there's a lot of literature to suggest, is that these relationships, that there are very limited relationships between these sections of networks. Many people may have aspects of these networks there, but there's absolutely no connections between the different parts. And essentially, if we kind of take the systems idea and put that onto the networks around someone's dying, they are exactly the same as a system approach on a city level. looking at that microsystem, how can we understand not only who the components are, but what the connections are between across disciplines, across communities, across different parts of that person's life. So that the urgent requirement is to begin understanding how we can make connections, how we can join up these networks. We found in our commission research that many many reports, strategies, guidelines from the WHO on healthy aging, reports on liver disease, frailty, etc. COVID-19 absolutely omit the idea of dying from any of these conditions. So they are just not, it's just not included. So COVID-19, healthy aging, etc. There's a sense you just continue. The focus is on rehabilitation or on ventilators, which obviously are essential components. But there was a real silence and an omission of understanding that death, dying and grieving will be part of all these healthcare conditions, yet alone are a part of normal, the fabric of normal everyday life. We also see how, whilst death is in some way sensationalized, on the front page of newspapers, it's the main line in TV programs, films, books. You know, death is somehow, in some ways, everywhere. But dying, as Catherine Mannix calls everyday dying, from heart failure or cancer in your living room at home or in a care home, that is something that's deeply unfamiliar and is not covered and not presented in the general narratives that people have access to in society. And often people I care for at home feel like this has come out of nowhere. They're suddenly confronted with something that is so unknowable, so unfamiliar, and that they feel so unprepared for, because they essentially have no script. This is something that they have not often witnessed with older parents and families. People haven't died till much later in life. So this is something that hasn't been part of their life. And because it's not presented in any of the kind of more formal policies and reports or media stories and storylines, there's no way for people to find this out. So we want to ask that conversations and stories about everyday death, dying and grieving become common across the spectrum, from media, stories in films and on news items, right the way through to formal strategies and policies. And this silence, this omission of death and dying must be addressed. And finally, probably the most abstract and in some ways hardest to articulate, the principle to look at the idea that death in itself has value. Now, this is not to say that all death, premature, avoidable death, has value. And this is not looking at individual deaths to say they have value, but this is looking at the concept, the idea of death in our lives. It has value. It bookends our lives. It is part of the survival of a very crowded planet, that actually we cannot all live infinite lives. And the idea also of caring for the dying. There's been a huge amount of literature going back thousands of years to try and capture and articulate the value that caring for people at the end of life, of that essentially shared commonality, that shared vulnerability and fragility, of the value of that time, both for that person dying, but also for those caring. And the value that then you take away, having considered, actively cared for someone, supported them. And we heard this in some of the talks this morning, that you take that away, you reflect on your own life, and actually that allows you to live your life in a very different way, and for many people, an improved way. So death is integral, death has value, and death must be understood as a part of our essential human condition. I want to finish with, this is one of the last tables in the Lancet Commission, I think my favourite, coming back to the idea of the kind of green shoots of the realistic utopia of change in the field happening around the world. And here we put in some of the ideas of how you shift change in systems, the leverage point in systems. So transforming the mindset, changing the rules of the system, changing the way information is held. And we categorize what this would look like for an end-of-life care, death and dying context. And they just give examples in the final column of where this is happening, where huge amounts of action, energy and input are coming in. So it's happening essentially. The roadmaps are there globally. The question is, how do we begin to make this something that is universally accessible, universally understood as important, and crucially moving beyond our our palliative care world, where we really understand and accept these challenges, and moving out to a much broader audience, both kind of professionally, policy-wise, but also into the broader public. Thank you.
We are very grateful for you, and you all should be, because she saved you hours and hours of reading that report. In 40 minutes, you got a crash course. And I'm not joking, for somebody like me and Kirsten, who's been trying to read it as well. Amazing work. Well done for leading the team in such wonderful piece of work, you know, and so international. Yeah, well done. So that's great. We can really start with a panel discussion now. But before we start, I'd like to introduce our consumer advocate, Mr. Jeff Thomas, or AM, who I've been working with in the field of motor neuron disease now for the last few years. And Jeff has lost his wife, Mary, to motor neuron disease in 2013. And he's always talked about the friendship circles that he has, and wanted to do more research on this. And then boom, I told him about compassionate communities, and he said, is that the same thing? So Jeff, you've got 5 minutes to wow the audience with your experience and your reflection on what you've heard now.
Well, thank you, Samar, and I share people's praise for you and your work in this area. In fact, folks, I'm so impressed that I've already booked Samar to speak at my funeral. She's friendship groups, whether they're the same as compassionate communities, I don't know. I'll leave that to you to judge. Maybe one's part of the other. But my comments refer to the management of well-being of people, in this case, my wife with MND, and I am working with MND associations across Australia in this area. I'm assuming that in my case, it's a terminal illness for which there was no treatment or cure. And like Alan Keller has said, we're one of the 95% that decided to do this journey entirely at home. If I had to name two areas which are important during this journey, I'd say the carer, because the carer and the patient really become one in the management of this thing, and the other is the friendship groups, partly because you're staying at home and within the community. And they're important during the entire journey from diagnosis right through to death. Both are areas which are undercooked in research. We know that, and thanks to Julian Abel for indicating why he thought that was the case within the current research paradigms. But folks, I'm not going to go on with that area, because I know how annoyed it makes Samar feel, and we don't want to start throwing things. So my observations on friendship groups would be these. They already exist, of course. They have established relationships, interests, communications. They have strong focus on sharing, on support, and on compassion. So if you look at it within the context of what we've been talking about today, they're obviously ready to go. But are they? If you look at a diagnosis of something like MND, and I suggest to you that grief, the process of grief, starts with the diagnosis. If there's no hope of cure or treatment, you know, that is really the death sentence. So grief starts at that point. And we observed that these friendship groups of people, they were shocked, they were concerned, they didn't know how to deal with their emotions. They wanted to help, but were confused. Some even withdrew. Others showed pity, many too much pity, because that's one of the things that people who are in this situation don't want. And many were overgenerous, particularly when it came to food, during the middle of this this journey, if I'd been given one more pot of soup or one more damn casserole, I would have gone mad. And all of this continues, of course, as the condition gets worse. They see the changes, and it gets worse, of course, again, if there is cognitive change, which was the case with my wife. So to me, the end of life in our case was really just part of the grief continuum, which went on for 4 years. But I suggest to you, in this case, it was grief touched with relief. In fact, at the time that Mary died, in front of me in my presence, I didn't know whether to burst into tears or to skip down the corridor. And that made it even more complex in terms of managing that grief process. So if we're to make these friendship groups part of the support structure, as I'm sure we all want to do, what do we need to do it? Well, firstly, we need, I think, as you've been suggesting, we need to recognise the recognition that these groups have a major part to play in the management of well-being. It'd be nice if those that are funding support for people that need care were to realise this, such as you'll have an NDIS will support a carer to come into the home, but we've got this great network of people that don't get any support for training or whatever. So it would seem to me, and I'm involved in some policy work, that if the government really wanted to make an impact, this would be a good way to start. We need to understand the role of the friendship groups from their own perspective, the patients, the health professionals, the allied health professionals and everything else, because sometimes this area can get pretty cluttered. We need to provide support and make them part of the journey. We need to be indicating to them how things are going to change and what to expect. We need to make them feel valued, obviously. But we need to watch overkill. As I said before, there can be too much pity, interference, all being well-meaning, when what the patient and the carers really want is to continue life as normal as possible for as long as possible. So who do we get to provide this support? Well, you can look at the MND clinics or whatever for argument's sake. They're largely involved with medical stuff and don't have time for this. We have MND associations and advisors, yes, fine, but they don't have the skills frequently and are reluctant to move out of the areas of work which they're engaged in. Because getting into the grief space is a pretty tough gig and requires very special skills. So who do we get? It seems to me that we have a raft of people out there in the community, many of whom have lived experience, with some training we could use as advisors, mentors, prompters, encouragers to get on with this sort of work and work with the community. In my own case, I do a lot of this. It is, strange as it might sound, an essential component of my grieving process. So, Samar, to questions. Where's Samar? I've offended Samar now.
I'm here.
Come on home. Oh no, here she is.
Okay, well, great. Thank you for your 5 minutes. Very, very insightful. Thank you very much. And it's been a pleasure working with you for the last, 5 years or so, and being on quite a bit of the articles that we published together. So I think now we can go to the panel discussion. So Jeff will join us as a panel member as well as all the speakers. Now, I didn't say that Jeff is in Adelaide, so truly, yeah, Australian. So now we have, thanks to Robin, she's compiled quite a few of the questions, really interesting questions we got from those present here and those on Zoom. So how do we start looking at that? Do we have them on PowerPoint? The first one really, and I get asked this a lot, and I'm sure Julian does as well, and Libby, how do we make compassionate communities sustainable? It's that sustainability question. The second one, not that one. No. Yeah. So what makes these initiatives sustainable after key people have moved on? And then there was another one. See if the one, do you want me to do it? The one after. You know, this, yeah. So we all start from small projects. Certainly the ones, we started the network before we got funding to do the research project with WACS. But this is a typical thing. So I'm a project lead for a small ComCom in my local area. My role is funded through a small community grant, but the life of this project is only 12 months. And I know it takes longer than 12 months to get community engaged, informed, etc. So has there been any research globally that shows any benefit in having active ComCom leads that coordinate, engage, and educate their local champions, neighbors, connectors who are paid versus the ComCom leads being voluntary? It seems difficult to continue the momentum of this engagement unless some roles are paid due to the considerable time and investment energy required to keep the momentum going. Yeah, so anybody from the speakers would like to answer this question?
Is this not part, Samar, of the wider question of what are the economic, quite apart from the social and emotional benefits of people staying at home and being supported in their home? What are the economic benefits of that? Now, we have discussed looking at a project into that. I mean, if we knew the answer to that, then it would be easier to say, well, then what is the cost and what are the requirements of having the community support that process? Not because it won't just be a cost. You can't look at just look at the cost of this. You've got to look at the savings to government, which have to be absolutely enormous.
Yeah, correct. And you know, from the perspective of paid versus non-paid, yeah, I totally agree. We really need to find a way of this becoming part of what we're doing. So for instance, just to give from the Southwest perspective, the only paid position is the coordinator of volunteers, of connectors. But at the moment, it's the network. After the research project's finished, it's the Compassion Community Network that's trying to find funds to keep that coordinator of connectors going, because she's the one who is getting referrals from the health service, matching the patients to the connectors, liaising with the connectors if they have any issues with the families. And how do we make this a voluntary one? I don't know yet. We're still thinking about this. I think it's going to be difficult making it voluntary. This is where we mean the partnerships come in between the formal and informal networks. WA Health, is this something you can help with in terms of making this as business as usual? I mean, it's all great that, you know, it's been taken up as business as usual, but it's still the community side of things paying for that role. It does save a lot of money for the health service. And of course, when Professor Angus Cook does the, you know, cost effectiveness and the economics, you'll find how much money we've saved, you know, the government by having this program. But it's just one of those things we need to talk to, you know, of course, the health department. How do we get the two working together and each have their share, I suppose, you know, it's a partnership after all. So that's my answer for this. I don't know, Julian or Libby, do you have something on that?
Yeah, I mean, I think there's a couple of things I would say. I'd say, unfortunately, in our kind of current consumerist world, value is often financial, you know, in terms of the value of things. People understand and see value if it's funded. And that's, I think, something that we need to push against. But there also is something about how we kind of mark these initiatives, these efforts, these processes as something that really needs to be run throughout all aspects of society. And that if you don't include it in the funding of whatever structure this sits in, whether it's health or social care or community development or community engagement. Where this sits, actually, it's a fundamental part of building community and building health and well-being. And actually, I think it needs to be recognised as that. And that will make a great deal of headway towards achieving equity, because if this is something that every community has access to, then actually that's something that then can build, rather than on kind of the hit and miss idea of who's developing it. That said, it can't be something that's entirely, state funded or run, because the whole energy of it is that it is community-led initiative. But how you get that balance of kind of sustainability of a funded role that then can support, catalyze, kind of enable that kind of community energy, I think is important. And I think one of the big things is moving beyond kind of palliative care and moving beyond end-of-life care in terms of sustainability, that actually this can't be something that we are the only people in society who are driving forward, and this must come from much broader elements throughout the general community, throughout different areas of health and social care and policy. And so that's the key to sustainability. We're kind of the early adopters, the advocates, but this must be more broadly accepted. And certainly in my PhD, when I started a project called Compassionate Neighbours, which is very similar to the Connectors, we had a game change when we brought in someone, a paid role in community development worker who'd been working in neighbourhood kitchens and neighbourhood renewal, knew nothing about end-of-life care, but came in, could engage, mobilise, support groups of people within the community to essentially develop agency and change their kind of local conditions. And that's when it was a real game changer for us. So I think paid community development workers are a really important part. And I think Julian's probably got some very important comments to say, Julian, on this point too.
Thank you. I agree with all that you said, and I would add to that is that maybe a way of thinking about this is to see this first of all as a social movement. That this is about the culture of death, dying, loss, and caregiving, and if we think of this in terms of funding, then we get caught up in the problem of building dependencies, because as you rightly say, when the funding drops out, then everything disappears. So if we're thinking about how do we build this as a social movement, and the Compassionate City Charter is a component of that social movement. But then at the same time, as we looked at previously, it's about the integration of professional services and communities and civic sector together. And I think Libby used the right word, is catalysts. So professional services can act as catalysts for communities, but you build in redundancy right at the very outset, because you want that sustainability to come from communities themselves, just because the way that people deal with death, dying, loss, and caregiving changes and communities come together. So I think there's a tremendous difficulty with the financial argument, because you have to get into the mindsets of the people who hand out the money. And good luck with that, is all I can say about that.
And they're here today, which is great.
That is true, but I think if I were one of those people handing out the money, Julian, one of the things I'd want to know, and I notice as a question come up, what are the measurable outcomes that we get out of this? As a minister, I would want to say, well, what is in it? I get this nice warm glow and everything else, but what is in it for the government? What are the benefits to the people? What are the benefits in terms of the economics of the government, in terms of community development, etc.? In other words, when do we know when we've arrived in the success of these communities? Because they won't go on forever unless we have a damn good business case, and a business case just isn't about money, of course.
I think it's a great question, Jeff, and I think we should be looking at the UN Sustainable Development Goals for answers, because when you take a community development approach, you see all kinds of things happen in a wide variety of different directions. This isn't just about death and dying. No. It's about everything in our lives, because it depends where you look as to where you see the outcomes.
Yeah.
And I would further add that Libby brought up the question of inequality. And actually, when you start dealing with issues of inequality, if there was any serious attempt to address the issues that we struggle with across the world, it is really clear that the size of the gap of the difference between the rich and the poor give you the worst outcomes. And so this is, you know, in terms of, this is what I'm saying about rationing and reasoning, you know, that when you try and get in the mind of the people who hand out the money, it's really tricky, because the things that help them make decisions are not necessarily the things that make sense to us.
No.
And I think that there is a really difficult problem about engagement. And the other really complicating factor is that we can argue till we're blue in the face that this saves money. But what you see is with healthcare expenditure overall is it continues to rise. And unless you deal with the overall rise in healthcare expenditure, then what happens is even if your service saves money, it doesn't make any difference because you have that continual process of cuts. But what I would say is that when you look at applying these principles to healthcare in general, as we've shown in Froome, is that you dramatically reduce both the overall healthcare cost and use of healthcare services. But even in that context, you know, arguing with commissioners about that is a very tricky business. But anyway, there you go.
Great, thank you. I think we've got a few more questions, but while we're at it here, the audience here, would you like to ask a question? Because I think most of the questions have come from Zoom, right? Yeah. Anybody has a bit? Yeah, Grace. It's a microphone there. Yeah.
To ask the question that in West Australia and the models that we've been shown today have all happened outside of the metropolitan area. Have you viewpoints on how you can see that working within the West Australian model of the metropolitan area, and that we don't really have the same viewpoints on local government as in the UK, for example?
Very good.
Yeah, that's true. I mean, things seems to be easier to do in rural areas in this space, but so we haven't had the experience yet in metro, but yeah.
And yet the demand and the need in terms of isolation and everything else, in my experience, can be just as great, if not greater, in the metropolitan area. You can be locked in if you are unable to, you know, limited in your movement, etc. The difficulties in engaging in the metropolitan area can be enormous. When you walk down the street and ask who knows their neighbour over the road, and I worry about the answers. So yeah, I think the metropolitan area is a different is a different issue, because you know, the local government, local community, I don't think relates to their people nearly as well in the metro area as they do in the bush. Yeah, where I happen to come from, I might add.
Yeah, but Jeff, I must say WA Health have funded 5 local governments now. Albany, Bunbury, we know that things happening there anyway, but there's Stirling, Kalamanda, and who was the other, Coburn? Yeah, so I think that's a pretty good initiative, and they've provided seed funding for local government to work and with their community to establish compassionate communities. So that's a good start.
Yeah.
Again, you know, our colleagues in Victoria have done a lot with that, with Bruce Rumbold and Andrea Greenrod. So things have started, and I think that's probably one good way of starting to engage metropolitan local government and communities.
Might be worth hearing Libby talk about compassionate neighbours in
I know London. It was in London. That's right.
Yeah.
Yeah, so I based the project that we started, which is again similar to the Connectors Compassionate Neighbours, and it's around building supportive networks in place around people who are dying or grieving. And we based this on the model from Kerala in India, where they've got mainly rural, but in cities as well, a huge network of volunteers supporting people at the end of life. And there was a sense that it would never work outside of India, that kind of specific context. And there was also a real concern that it would never work in a highly metropolitan place like the centre of London. But we trialled it, we piloted it over 6 years. And actually what we found was when we went out to where people were congregating or where communities were, then we had huge input and huge interest. And you're right, the number of single person households in London is so high. People, many people have, families have emigrated, moved, died. And so we saw a large number of highly isolated people. But what we found, if we went to lunch clubs, to libraries, to cafes, where people were still meeting, there was a real desperation to be connected to their neighbours, to help, and also the sense that actually of a real acknowledgement of the isolation and that something needs to be done about it. So when we held these open days, we'd have hundreds and hundreds of people come from all different ethnicities, areas, apartments, flats, working, young mothers, students, older people, retired, a huge variation. And we began to talk to people about loss in its broadest sense. And actually what was amazing is it cut across hugely different life experiences, was really uniting. And people came together in these really diverse groups, much more diverse than I guess you'd have in a smaller rural area where people didn't know each other before, but were all living on the same road or in the same apartment block, and came together. And they're hugely resilient, sustainable models that are still going 6 years, 8 years later now. But it was just something that people didn't think would happen because people are living in different structures. But I always advocated that people are still people, whether they're living in cities, in rural villages, people, and the strength and wish to connect will always be there. So if you go out to ask people, would you like to be part of something like this? And as Julian said, we just catalysed this existing wish and gave people a framework to connect on it. And it's been enormously successful. And it's both looking in rural and now in rural and urban areas.
That's great.
Great.
That's great.
Thank you. So I'm going to move on to the next question. And it's about how do you convince palliative care practitioners to actually embed, well, I'll read it now. But the relation between the community and the professional. As a community development practitioner, I believe in the community is the subject to every intervention. I observe that the community has a rich resource of death literacy, such as sociocultural knowledge about death of their heritage. How do we help the community realize their capacity to play a more important role in the current medicalized dying experience? Anybody would like to answer this one? Can I see that?
So yes is the answer to that. And I think that the whole public health approach that's been developing over the last 25 years is really a way of engaging the professional community. And now that public health palliative care is part of the curriculum for the training of specialists in palliative care in the UK. And actually, I think the textbook, the Oxford textbook, is a big help because it draws together all the information for the first time, which is really comprehensive. So as well as there a need to create a social movement around death, dying, loss and caregiving, there's absolutely a need to create a professional movement where people can deal with what I've called the palliative care blind spots and take a whole population approach that sees that death, dying, loss and caregiving is a social event with medical components to it. And that's about the professional engagement.
Can I just add to that, Julian? There's a question that came a little bit after that first question from Bianca, and professional struggle saying no to people and have to help, but with it comes this kind of this control over people. And I'm just reminded of when we were doing the Death Literacy Index validation, actually when we were doing some of the, preceding that, we did some interviews with healthcare professionals in a country town to say, who could be involved. And the answer of one healthcare professional was, well, nobody that we haven't vetted, because Mary, the next door neighbour, could be an axe murderer. Now, there's a whole debate around the risks associated with associating yourself with large institutions, but there was this real mistrust that somehow, if it was unregulated, it couldn't be of value. And so I think the kind of the response to this idea that that there are two reforms or two places of development and evolution to happen. One's within communities and the other is absolutely within the professions. As an academic, I can see it moving excruciatingly slowly, but cultural change always is. But I'm sure others would contribute to that point.
Yep, thank you very much. The next one is about end of life. I think Compassion UK builds community knowledge, skills, and confidence around end of life care. How do we build the confidence of clinicians that the community can be an equal partner?
Which is really what I was getting at, was that it is cultural change, but also there are resources from all over the world that have addressed this. And I think Libby, you actually, I'm looking at one of the chapters. I think you looked at this a bit, didn't you?
Yeah, and I think I'd also extend this question, the response, to say the frame needs to be beyond palliative care professionals, and actually we need to be looking more broadly at all doctors, family doctors, nurses, social workers, you know, all people involved in health and social care need to be educated within this. And I, say this as a palliative care consultant, and I completely see I almost have two work modes, my kind of research mode and my clinical mode, and it's really, really hard to integrate this into a kind of pre-fit system, that wasn't designed for this, and there isn't space for that. So you have to create that space. And as Julian was saying, in the UK, we've now got public health palliative care into the palliative care curriculum, which is amazing. And so we'll have an entirely new generation of palliative care doctors who have been trained in this, who understand the rationale, the kind of the rhetoric and the evidence. But I think we've got to make sure that we're educating professionals in the role of community across the life course. As I keep kind of coming back to, death needs to be not seen as this separate and special event. Will be met with the same kind of challenges that we've kind of experienced throughout our whole lives. Now, obviously, there's a huge amount of specific input that's needed there, but we shouldn't kind of separate it off. Only palliative care manages this, or only compassionate communities manage this. It must be seen as, how do we build supportive networks throughout our lives to deal with all the multifaceted areas of loss that we experience in our lives, of which death is a huge one. And that's where some of the sustainability comes in, that it isn't palliative care, because I often see people in my practice for the last week of life, and I can't get anything built in that time. I can't build those sustainable networks. It has to be earlier on, and it really should be prior to serious illness diagnosis, because as Jeff really eloquently said, grieving starts at that point of diagnosis, and you're dealing with something that's changing all the time then, and actually you want to draw on things that are well established prior to that. And so that question is how we begin looking at that throughout the life course, how all health, social, government, council professionals understand these as natural events in our lives, but needing significant amount of support around them.
Yeah, great. And this is
Can I
similar
just add
to,
something, Samar?
Yeah, sure.
So I'll add it from the point of view of a small town and a small services. I think lots of us in the room are working clinicians, and our spheres of influence seem quite small, but actually that's also a start. So obviously, I have already ordered, by skipping out of this and getting online, that textbook. But I do think that we can all provide leadership within our spheres of influence, and we can ask those questions about, where are those partnerships? Or we can, in our day-to-day clinical interactions, we can continually be coming back to these principles of love, laughter, friendship. Who are those people? We can start to build the questions of what matters most into our everyday histories. So there is small spheres of influence that I think we can all have. And I hope part of what I've tried to do during my practice is work with sometimes those small spheres of influence, and hope that those ripples also extend out, because we are training 1, 2, 3 people at a time, or we are having people come and go into our teams. And I do think we've got the ability to also chip away at things, even if we feel you know, I'm just a doctor in a rural town, or I'm just a nurse on a general medical ward. How can this big thing how can I have any part to play? So I'd also encourage you just to remember that chipping away, challenging the status quo, leading within your sphere of influence, and hoping that the ripples do spread out. So you might be the nurse on the floor, for example, that says, why can't we show that person, their family and their carers out there how to give that injection? You can be the facilitator. You can be the one that gives them some of the information about, you know, what's really important here is relationships. So I'd really encourage you to think about that all of us have a role to play as well, although for many of us it's a lot smaller.
Thanks, Kirsten. You've answered few of the questions, really. Sorry, Julian. Yeah.
I was just, I'd just like to say that, you know, meetings like this, I think, make an enormous difference. And I don't think you should underplay what you've done, Kirsten, because you know, and the work that Samar's been doing, you know, and the work that Luke does along with Joachim and Libby in the big project in Belgium, is that as the evidence comes out about this stuff, we share it amongst the professional community, and that inspires the professional community as a whole. You know, when we look back, we see this as a small practice examples, an idea started by Alan Keller here in the 1990s that has become a worldwide movement, and it continues to grow. And the practice examples of the application of these principles is incredibly inspiring and really helps. So it's not, you may be doing it in a small area, but it has a big impact.
If you started this in the 1990s, Julian, you must have started in your early teenage years.
I wish that were true.
Samar, being an outcomes-oriented sod, I think it's been a great seminar. But what I would like as Aussies, and particularly looking at the Mondos project and the MND people, is what are the issues that we can take out of this? And we can't answer this now, but I think take it on notice, and you might get a small group together before you have your drinks to identify those issues that they need to address, and then engage the great group of people that we got here to further some of those issues, so that we don't just go away being more informed, but we go away being more armed to move it ahead in a positive way.
Totally agree. We've come to the end of our session, but there's one question on Albany project. Would you want to put it? Do you want to read it there? Oh.
So I've got it on the screen in front of me. Am I interrupting because I can't hear the person saying the question?
The Albany project had a focus group with Aboriginal people. Were there lessons learned from speaking with them about community and culture from a people who, to me, as an outside observer, have very different attitudes about death as part of life?
Did you hear that, Kirsten?
I did. So yeah. I think in our community, working together, particularly in a research domain or in a policy domain, comes down to relationships. So I think working with the Aboriginal elders here and the Aboriginal young people, we do need to be in a place of trust, because there have been terrible traumas perpetuated. But I think the lessons we've had from this focus group, but others where we've talked about palliative care, end of life, advanced care planning within our region with our Menang people, is that they are very open to these conversations. They have great insights. They can give very clear advice about the best ways to work. They want to solution generate as partners. But I think particularly those conversations need to happen in an environment that's experienced as safe. And then I think our part is about listening. So the lessons we've learned haven't necessarily been the dot points of do this, do this, do this in terms of attitudes to death and dying, but it's more about that general approach. And I guess the real take home for me is working throughout the state of Western Australia is that you have to ask people when you get to where you are, who should I talk to? Can you give me some advice about how to go about that? And you need to really respectfully be guided into those conversations in the forums and places where they can be held. I'd also say, though, that Julian has put quite a lot of really good references in the chat, which I've taken a photo of before that chat disappeared too far, and that there are also some really excellent Australian resources. There is a repository through ECU about end-of-life research resources and other resources for Aboriginal palliative care. There's some great modules from Guandalan at the moment that we've got. And I think many of us now have Aboriginal people working alongside us in our community development or in healthcare. And I think they may well be good places to start, just to talk to people about how this looks to them.
And that sounds great, Kirsten. And I would add to that is I run a podcast called Survival of the Kindest. And I've spoken with quite a lot of Indigenous people on that podcast. And I always feel slightly embarrassed, to be honest, because we have recreated community development, which has often the same language that you find in Indigenous peoples. And they look at us slightly strangely and go, what do you mean we've been doing this for thousands of years? And so there's another way of thinking about this is, well, how do those communities function? And we can ask those questions, and we take the perspective of becoming learners for deep knowledge. And there's quite a few podcasts where we talk about that. It's well worth listening to Holly Prince talk about it. And we spoke with Tyson Yunker-Porter from Australia about it, from Nicole Hewlett, who works in the palliative care space with Aboriginal communities, and quite a few others. And they all, I just feel silly for talking about compassionate communities and community development. Like, oh, yeah, sorry, you've been doing this for a long time.
No, and coming from another cultural perspective, that's exactly what we do. We used to do, you know, all that sort of that kind of work. And again, you talk to somebody from sort of my community, they would look, well, so what's new about this? You know, like we're doing it. Yeah. But anyway, look, I think we need to wrap up. It's been fantastic afternoon. As I'm reading the chat, everybody's saying was inspiring. Thanks a lot for our speakers, John, Julian, Kirsten, and Libby. It's been fantastic having you together. Now, I must remind everybody about the International Public Health Palliative Care Conference in Bruges, 21st to 24th of September. If you haven't registered, please do so, because there'll be a lot of these discussions happening there. You know, again, Jeff, thank you for joining us. It's been very valuable hearing your perspective.
Thank you.
So this is going to be recorded. So I guess we can share the recording with everybody who's registered to be on Zoom or otherwise. We've got refreshments outside. Sorry for the Zoom people, but we'll have a drink for you. Any further questions that we have on the chat box that we haven't answered, we'll compile the answers and send it to everyone. And that's about it. Thank you very much for joining in. It's been very, very, you know, endearing for me to have all those wonderful speakers who are so knowledgeable about their fields. And until we meet again, thank you very much. Bye-bye. And can I just say thank you very much for all the Perron staff. I've mentioned them at the start so that I don't forget any of them. But of course, Taya and Robin and Kate have been fantastic. And can I just say also thank you to Professor Norman Palmer, who instigate these symposium. And he hinted, do you think it'd be good to have a symposium on palliative care? I said, yeah, why not? That ended up to be quite a lot of work, but very, very rewarding. So thank you very much, everyone. Thank you, connectors in the Southwest as well. Sorry.
Get the chat as part of the recording, right? It's coming up saying